Hey, Lenny,
Yes.
is is Raj? I wonder if Raj passed out from all the typing he's been doing in the background.
I'm here. Oh my God. I am going to get carpal tunnels.
So one thing that I'll say over the last day and a half is there's been a lot of questions regarding one thing is transferring the results that we see when we equilibrate our study models and how do we translate that into the mouth? And that's a really great question because equilibration seems like a very intimidating procedure, and it's not. It's actually a very simple procedure if you learn to do it correctly, which is why a lot of these more advanced types of skills need to be reinforced in a hands-on setting. Because there are things to consider when you're equilibrating a class one, a class two, or a class three patient. And the good news is that when we transfer what we learn to do appropriately and conservatively onto a study model, that absolutely translates exactly what happens in the patient's mouth. But there are very distinct techniques that we need to learn to equilibrate correctly. Dr. Dawson used to always love to say that there is no such thing as an incomplete equilibration. It's either done correctly or incorrectly. There's no in between. And whatever we do, if equilibration is a part of our treatment plan, when we get finished, those 5 requirements of occlusal stability need to be met. The other thing that I'll say is a lot of times there are questions that are coming about with regard to diagnostic waxing and who should do it and when should you do it. And the reality is that every dentist, if you're going to work these cases up, needs to be able to perform what we call the minimal treatment planning wax up. And so what that means is Dr. Cranham has then been going through these cases. He's trying to figure out what's my ideal lower incisal edge position vertically and horizontally, what's my ideal incisal edge position horizontally and vertically for the maxillaries, and then how are we going to bring the teeth together? How are we going to work our anterior guidance and our envelope of function? So it's our responsibility as the restorative dentist to make sure that we determine where that goes. The laboratory doesn't figure that out, we do. So we need to be able to do a minimal wax up that if we want to be able to send it to the laboratory and have them make the teeth look super beautiful, because we don't want to do that, that's fine. But it's still our job to really figure out where the teeth need to go in space and how that functional arrangement is going to happen. And then we can send it to the laboratory to finish that up. And again, this is another skill. When we start going through, like on our screen right now, we see our core curriculum up there. And this is a skill that we really gain in the phase 2 of the core curriculum, our treatment planning functional aesthetic and excellence course. We take you through actual cases from start to finish, all the way through the diagnostic process. So you learn these skills and then you can take them back into your practice and feel very confident that you'll be able to get the very predictable result that we're looking for in a lot of these complicated type of cases.
And to kind of piggyback on that, a lot of the questions that were coming in were related to how do we finish up the ortho and how do we decide where those teeth are going to go? And it piggybacks just on what Lenny just said, is that this is part of the diagnostic process. We're not compartmentalizing the orthodontics, whether it's Invisalign braces or clear correct, whatever you're going to use. It's part of, we've come up with a diagnosis and a plan of where these teeth need to reside. And the orthodontics is part of that solution. Remember, we always have 4 treatment options, and we use combinations of those treatment options. So if we decide we're going to reposition the teeth, like in this case that Dr. Cranham just showed, he did repositioning and restorative, but he also did an equilibration. So we're using combinations of our 4 treatment choices routinely to achieve our final most predictable result.
Yeah, in some cases, Raj, like you, we do all 4, right?
Yeah. Oh, yeah. Yeah. Completely. Yeah. In mine, that's exactly. Mine was all 4. No restorative,
Yeah.
but so I had 3 out of the 4.
3 out of the 4, right? Yeah.
Yeah. But a lot of times we will need all 4, or routinely 2 to 3 out of the 4. But we have to envision our end result in our mind before we start, and that's the diagnostic phase. As we're getting our between the diagnostic phase and our treatment planning phase, we know where we want to put those teeth in the end, and then we kind of back engineer that to figure out how we're going to get there. And our checklist, that people are always talking about the order and asked over and over again about the order. We don't stray from the order in our checklist. That's when we get into trouble. We don't want to have trouble. We want to have predictability, and we have to stay in our order of our checklist that you'll see, our 10-step treatment planning checklist. That's plastered all in our minds. We adhere to that, and that's what makes us stable and predictable.
Raj, you just reminded me of a great Pete Dawsonism when we talk about that getting your tail in a crack. It's a sure way to get your tail in a crack, he used to say.
Yeah, if you think you're going to try to go faster by skipping a step, or that's the longest. The shortcut is the longest distance in between 2 points. And it doesn't mean these things have to take long. Sometimes it's just minutes in the decision-making process, going through your steps. But you have to do things in order.
Well, one of the things, as I think back to when I was going through this curriculum for the first time and learning these skills, as I sat in this very class, was number one, there was a degree of panic, because I realized that my world was just opened up in a way that I wasn't expecting. And I thought about all the patients that I had already treated, and maybe some of them that maybe I treated them wrong. And I would feel very overwhelmed. And so I would wonder, where in the world do I start? And where I start is by learning to function and learning to work cases up from centric relation. And so one of the core foundational principles, that if this type of information is starting to light a fire within you, that you want to be able to elevate yourself as a dentist and to be able to handle these types of cases in a more predictable manner, this all starts with learning to reliably and predictably record centric relation, how to do the complete examination correctly, and how to utilize a FACEBO, and how to get myself into a position where I can analyze these cases in that starting point, which is centric relation. And the reality is that this is something that you have to learn it in a hands-on manner. And it's not something that you can learn to do in a webinar, because it's a foundational clinical skill. And everybody out there right now, that if you're thinking, well, what do I do next? What's my next move? Your next move is to think about, how can I set up my schedule and my life so that I can do that first hands-on class, so that way I can feel confident with my ability to record centric relation, and that will help you to feel confident to get those predictable results that Dr. Cranham has been showing us over this last day and a half.
Yeah, that's great. You know, I mean, it's not a coincidence that I dragged Lenny and Raj in here, because you guys really are the faces of examination and records, right? I always kind of see you guys as like the John Hammond at Jurassic Park. You know, when the doctors first hatch, you're like the first faces they see in that examine records as the light bulbs are going on. So if you could talk about some of the stuff that you've seen from the students that take this class for the first time, I think that would be nice to hear.
Well, you know, one of the most amazing things about being able to function from centric relation, and our greatest responsibility as a dentist, and this is one thing that I think people really kind of get their mind open up to, is that all of these patients that we're showing that end up needing expensive, complicated dentistry, at one point in time, these were young people that were showing early signs and symptoms. And if these people had been diagnosed at that point in time, they wouldn't get to the point to where they need 20 units of crown and bridge or orthodontics and all this. There are so many of our patients that the sooner we have the ability to diagnose these signs and symptoms, the more conservative and less invasive that we can be to actually get them into a stable relationship. Because ultimately our goal is to keep people from needing what we do, right? Our goal is to keep people healthy throughout their life and keep them. Now, don't get me wrong, there's going to be plenty of people out there that are going to need us. There's still 7.5 billion people on this planet, but it's such a beautiful thing to when you can keep somebody from becoming a 45-year-old train wreck. That's really one of the most, I think, eye-opening moments that people start to realize is you can do so much good for the people that have problems, but it's so rewarding to know that you're keeping people from actually needing us in the future and preventing them from having bigger problems.
That's a great point. Several of the questions yesterday were coming in about, well, what if you have a little bit of wear in the canine? Is that okay? I kind of relate that to having a little bit of cancer. It's a sign of occlusal disease. When you look around the mouth and you see occlusal disease, the earlier you intervene, the more conservative your options are going to be. And once you learn how to see, you can't unsee it. But your treatment planning, the earlier you get in on intervening, the more conservative you can truly be. And it doesn't have to be a full mouth rehabilitation. You might need a little bit of ortho and an equilibration and maybe some composite early on. It might be even more conservative than that. And some of the stuff we were talking about today, if we can intervene on the developmental stage of people as we are realizing they're going to turn out to be unstable, maybe we can modify some of their growth patterns. So yeah, we can intervene at multiple stages. And as Lenny said, there's always people at the whole gamut. We see the whole spectrum. So we see the end stage and then we can restore their whole mouth, or we see the early stage and we can change their developmental process.
So Lenny, Raj, favorite part of the examine records course for you guys?
My favorite part, I still remember sitting in the back by the first break, leaning back and finding my own CR. Just kind of like pretending to fall asleep and hitting my first point of contact and saying, oh my God, and then going to the records class and then noting that and seeing what my big CR on my slide was. It was just like earth shattering, and then thinking about patient after patient, and then I don't know, seeing fractions differently and as potential causes. It's just an eye-opening moment, as Lenny just said a second ago, as to, you know, this applies to so much of what we do. And yeah, it's just that eye-opening aha moment for me.
Well, my favorite when I'm teaching examination and records is taking a group of dentists that, for the vast majority of them, have never recorded centric relation before. And there's a lot of misinformation about centric relation. There's people that think it's not predictable, that you can't get the same recording twice. But what we actually show you is that centric relation is so precise that we record it down to the tip of a pin through a measuring device on articulators called a centric. And what's amazing is we'll have this group of dentists, all of them taking multiple centric relation records on the same patient and finding that they've recorded pinpoint accuracy on 3 different bites on the same patient. And how we have been able, over the last 40 or 50 years, we've refined our techniques, we've refined our materials that we utilize, that it can be taught in just a day or so, that it's so predictable that brand new dentists who have never done it can get it that accurate. And that is such a glorious thing to see, and it always puts such a smile on my face. The smile on the dentist's face is always bigger than mine, but I'll tell you what, that makes that cocktail party after that day feel even sweeter when you see how happy and almost astonished the dentists in the class are that it is just simply that easy and predictable if you just learn to do it the right way.
It is pretty amazing, because that day or so leading up to that, they're like, can I do this? Can I do this? Can I do this? And it is true proof in the pudding that it is a reproducible, very, very specific point. And it is amazing to see that hit that over and over again. And then I'll chime in one more thing on that when you get to the treatment planning. And when you realize that you can actually come up with a plan that fits any patient that walks into your office. You literally will come out with that sort of confidence that it doesn't matter what they come in with. You can treat any case, any single patient with the format and the methods that we teach. There's nothing that's too complex.
Well, that being said, I'm going to have to sign out. I'm going to have to leave here. And I want to just thank all the participants that have been listening. And I've really enjoyed helping you on this process by answering your questions. And I'm really looking forward to meeting, hopefully, lots of you somewhere down the road in your path and your journey as you become a complete care dentist. So I want to say thanks to everybody, and I'll see you down the road.
Thank you, Lenny. Appreciate you being with us.
There were a lot of questions also about implementation. I think we're going to get to a lot of that this afternoon. But as Lenny said earlier, when you go through this, don't feel overwhelmed. I mean, it is overwhelming, and I can't take that away from you necessarily. But just know that we've all been at that point, and it's just a matter of figuring out how you're going to fit this into your practice. The first thing is that you're learning to, and learning to see is important, because otherwise, if you didn't see it, you couldn't do anything with it. But we'll talk a lot this afternoon about how we can start implementing that in the practice. And then, as Lenny said, figuring out how do we go to our next steps. That's what's going to be giving you the confidence to be able to do it.
Sorry, I had to drop out there. John Cranham called me. Go figure it out.
You okay?
Yes, we're just lining up our special mystery guest for later this afternoon. So just trying to make sure.
Some people were saying that they're having a hard time downloading the manual, Greg.
I'm wondering if it might be a result of not copying the entire URL. So I'm just going to put the URL in the chat. So you literally just copy all that and then paste it into your web browser. But I know that it is working because I am seeing people downloading it. So
yeah, I've done it 3 times and it works every time. Do you think it matters which web browser they're using?
It really shouldn't. No, it should just grab it. It's just a link. I say that, but there are gremlins in every machine, right?
Right.
That's how some of us stay gainfully employed as miracle workers. So I'm working on that.
You are a miracle worker, yes.
So I was just kind of, Raj, any questions that you want to bring up? I see, based off the conversation we were just having in the Q&A, somebody anonymously asked, what's the rationale to restore before repositioning bone in the 4 options? I have my answer for that, but.
To restore before repositioning bone. Well, if you're going to do any orthodontics or any repositioning of bony segments, we're usually going to do that before we do any restorations. Now, that being said, if the tooth morphology is so missing and you have truly destroyed teeth, in some circumstances, you could probably bond some of those teeth to get a little bit of a better idea of where incisal edges could reside. But I would never do any definitive restoration on those teeth because it's just, you're adding too much guesswork into it. So I would never do anything definitive. But there have been a number of cases where I had enough of a worn off incisal edge that even envisioning where that tooth was going to be was a little bit difficult. So I did my wax up, and then I converted my wax up to bonding in the mouth, and then I moved the teeth that were at least better contoured. And then I came back and restored them later on, even if it was going to be bonding or prosthetics. But at least it gave me a slightly better view as to how we can move those teeth around it. And if you're going to use Invisalign, it actually gives you a little bit more surface area to move with. So I've done that numerous times with great success.
Yeah, and I also might think one other thing is don't take the 4 R's in any particular order.
Oh, yeah.
They're just the 4 R's. We're just organizing by R's, and that's the way it fell. So don't ever think this is the 4 steps I got to take.
No, exactly. Not in sequential order.
Yeah, I just so we're clear on all the basics.
A lot of people did ask about, do you still have to reshape afterwards? Lenny did mention about how conservative it is, but I just want to say the equilibrations that we do are not the equilibrations that periodontists used to do, where they flatten everything. We're sharpening cusps. We teach that in the art and science of equilibration in extreme detail, but it is a very fine tuning or sharpening of the anatomy. It is not destructive in any way. If we, on a trial equilibration during our workup, realize that we were taking away too much tooth structure, then we'd be employing one of the other R's. Then then we might need to reposition a tooth. It might turn out that I thought that the case was going to be of repositioning. Just to go back to what Dr. Cranham showed my personal case. I went in to see Dr. Cranham thinking I was going to be in equilibration. I actually set up a visit in his office so that I took a vacation week off. I got records on Monday. Tuesday, we were supposed to just review the case, and Wednesday, I was supposed to be equilibrated, and Thursday was going to be a follow-up. But when we got the records, he gives me a call and says, we got to talk. Come to the house. And so we realized that in his model workup that reshaping was going to basically destroy my posterior teeth. So that's when he changed his, he used a different arm. And that's what we do. So reshaping is extremely conservative. It's not just indiscriminate. We plan. We're not exactly worried about exactly where we're equilibrating, but how much is important. And if it's not going to be our main option, we're going to come back and finish that case, as he showed you earlier in my case, with a reshaping after we reposition, or in my case, reposition the bony segment as well.
So Raj, I got another one for you, and this is totally off the mark, but I did see some questions about people asking about study clubs.
Yes.
I know that you run a virtual study club, as well as you have experience running the gamut of all study clubs.
Yes.
So
a couple of online study clubs going right now. If you're in an area where we don't have a study club, I would definitely direct you to the Dawson Academy website. We have a page for study clubs, and we have study clubs popping up all over the place. So hopefully there's a study club that you can go to in person within 100 miles or so of you. And if not, as you go through the curriculum, maybe you can become a study club leader. But that being said, we do have virtual study clubs as well. And since you've been taking this course, you will be authorized, I believe you'll be, I don't want to overstep, but I think you'll be authorized to become a part of the Dawson Association, which also gives a whole bunch of online content on a regular basis in addition to this. But
that's correct, Raj. Yeah, that's correct. And you can find information about that on the website under the membership tab as well.
Yeah, I believe I'm sharing that right now with everybody.
Okay, great. And also, let me mention, there have been a lot of questions about the Wizard, how you can download the Wizard. The Wizard is an online treatment planning tool. It's currently under redevelopment on a new platform, so it actually cannot be downloaded at the moment. I sent an email out a little while ago to the developer to see if he had an estimate of when it will be done, and I don't see an answer yet. I have that going on my other computer over here. So, but as soon as that's available, it'll be on our website, and we'll certainly let everybody know. The cost has been like $99 a month, but I do not know if that's going to change with the new development. So the platform that it was built on has become obsolete, so it's being redone on a new platform. It is an amazing tool, and when you come to the hands-on classes, you'll be working with it there.
Yeah, I think too, the other thing that's cool is, you know, previously it would primarily was just on, you know, working with laptops, but it'll be able to be iPad and iPhone and all that compatible, which will be really slick to be able to share cases back and forth, which is what it's totally designed to do. Okay,
great. Davey King, if you're listening, could you raise your hand? Because you asked a question back at 8:30 that I was going to have answered for you if you're on. So if you're on, raise your hand. There you go. Okay, John. All the way down at the bottom, Davey had a two-part question. It starts, we say that when we change vertical, that we revert back to the original vertical, maybe up to 6 months. Please compare the adaptation of posterior teeth where the forces are down the long axis compared to anterior teeth where the forces are more horizontal.
I don't want you to really think about the teeth, because it's not the teeth that are adapting. It's the alveolar bone that's adapting. So if you think about the teeth being housed in the alveolar process, the whole alveolar process, if it's intruding, is actually shortening against the basal bone. So if we visualize it, there's probably a little bit more in the posterior than the anterior when that occurs, because on closure, there's 3 millimeters up front and a millimeter in the back. So again, don't think of this as intrusion as much as it is remodeling of the alveolar process. Now, having said that, I do think it affects the position of the teeth a little bit, because when we follow those people with T-scan. I do have a little bit more tweaking of the occlusion to do as we go along, but it's not much. And as I say, if we're following the 5 requirements, we're in centric and we've got good stops and good guidance, the patient isn't even aware that it's happening.
And then his second part of that was, is some of the adaptation due to muscle lengthening and or muscle relaxation?
All the studies indicated, there was a lot of studies done, kind of, if you're an animal lover, kind of horrible studies with rhesus monkeys, where they open verticals and then sacrifice the monkeys, and then we're looking, and there's no indication that you get sarcomeres lengthening. So people may adapt to an extent, but there's no muscle lengthening that occurs. We think it's all in the bone. Do I think that there's a range of vertical people can tolerate? Absolutely. And I think it's probably different from patient to patient, but there is some adaptation that occurs. And the point is not to say that you can't change vertical. We can change vertical, but we're not restoring vertical. When we work on worn dentition, we're opening vertical.
Okay. Harleen Gangi, if you're on, would you raise your hand? Because you asked your question at 8. Oh, there you are. Okay, great.
So cool.
848, he asked, some TMJ patients complain of pain radiating to arms, legs, and even backache on the affected side. Can you please explain the relationship?
That's a tough one, isn't it? But there isn't any question we get referred pain. And I'm probably not the best one anatomically to ask. That'd be a great one for a Henry Grimian or somebody like that. But there are definitely neural pathways that get affected. And when we have chronic pain situations and the sympathetic nervous system gets involved, we definitely can have kind of strange things happening. And that's why I'm never really surprised when we get somebody in a splint and they start feeling better, some of the things we hear them say, and I can't always explain it. I mean, one of the most common things is tinnitus in the ear. I mean, I've been told a million times why that happens, but it's still amazing to me that, we see some patients where the ringing in the ear goes away. Can't promise it, but sometimes it happens.
Let's see. In sleep apnea patients, how do you compensate for the large diastema after doing SARPE or MARPE?
Ortho. Yeah.
On the maxilla.
Yeah. Anytime you do a SARPE or a MARPE, it's got to be ortho. And it's all a matter of, if you think about it, if you've made the arch form bigger, they're going to put in orthodontics and slide everything towards the midline. And again, sometimes they'll close the spaces completely if you have normal sized teeth, or sometimes they create ideal spacing for us to then do restorative. But it's always, you cannot do that and not follow orthodontics.
Okay. How do you check vertical procedure? I'm not sure I understand that question.
Maybe they're asking, I think I know where that question is. So there's a lot of people that think that you want to test vertical dimension to make sure people are going to be comfortable. So they'll recommend doing a splint first. And there's no need to do that, because as we said, people are comfortable at different verticals. The key is that they're in centric relation and you've got the 5 requirements of occlusal stability. And so if you put a splint in somebody's mouth to test vertical, it's often not a very good test because the splint's bulky, and so it's just not something we do. We will test the vertical once the provisionals are in, and that's when we work out the occlusion. So I think that maybe is what the question was aimed at.
It says, can you show how to do vertical?
You just do it on the articulator like we showed you. Yeah, just open it up, right. Look it over, bite and overjet. Yeah. One more, Joan. I got a lot to do. So.
Okay. Do you do Michigan splints? Since you're from Michigan, I thought you'd like that one.
Yeah, Michigan splints. We'll talk about CR splints in a little after the next break, but we do a version of a Michigan splint. How about that?
Okay, we're ready.
All right, let's talk about the complete exam. So what I want to do with my time remaining is I want to talk a little bit about how we bring a new patient in, the importance of doing the exam first to be able to properly categorize your patient. And then we're going to go into exactly what we do in the advanced records. And then from there, we are going to talk digital. So show you that if we go through this properly, how can a digital transformation work? In other words, how can we go ahead and make sure that this is going to be appropriate from the standpoint of where we're going? So let's go ahead and get into this. And remember, one of the questions that we have to ask over and over is, what is the patient type? That's really your purpose of this complete exam, is to figure out whether after you've done looking at the patient, are there no signs of instability and the patient has a healthy joint? And what I, again, want to really have you do when you go back is make sure you're doing this thorough exam, because I find a lot of dentists will say, yeah, well, they weren't complaining about anything. This isn't about symptoms, right? This is looking closely at all the parts of the masticatory system to make sure it's functioning properly. And here again, if they are functioning properly, you absolutely can work in the patient's maximum intercuspation, which is ultimately what we're going to do. So MI is appropriate on those patients if they truly have minimal dentistry to do and they have no signs of instability. The second possibility, of course, these are your general patients, but the second possibility, of course, is now you have tooth wear and erosion, tooth mobility, muscle pain, and issues with the lateral pull. So if the early joint change, but the medial pull is still intact, these are the people that we can start getting that additional data on the photos, the models, and start working appropriately. And these are the patients that we're going to either equilibrate, reposition, restore. Getting a little reverb there. Can we mute whoever that is?
Yeah, I'm trying to figure out where that's coming from.
Okay.
Okay, all right, there we go.
Okay. But anyway, these are the patients that we're going to equilibrate, restore, reposition, do orthodontic surgery. But this is where we are going to work in CR and fulfill those 5 requirements of occlusal stability. And then the last possibility, of course, is we have the true internal derangement, medial pull problems, degenerative joint disease. And this is the patient where we've got to get the joint stable first. Before we do any sort of restorative or ortho or surgery, we have to get to that adapted centric posture. We call that the treatment physician approach, but these are the specialty patients in our practice. So categorization is key. And I want to be clear, we make the decision about how we categorize based on this TMJ occlusal exam. So if you are going to ask me, what is the one thing you should start doing after this class, this is what you should start doing. Because you're already looking at the teeth, you're already examining for caries and looking for teeth that might have cracks, and you're probably getting some periodontal probings and doing mobility. And there's just a few things to add. But what this does is this allows us to assess the entire masticatory system. And so, again, we're looking at the joints, the muscles, and the teeth. If we think about the history, we think about range of motion, we think about the load test, and we think about listening to the joint. Those primarily are aimed at the joint. Now, history tells us a few other things as well, but we learn about joint disease in that part of the exam. We learn about whether the muscles are symptomatic or not, or potentially have sub-threshold symptoms. In other words, they're sore, but only to palpation by doing a muscle examination and palpation. And we're going to look at the teeth here, right? Imaging is not something we're going to do on every patient, but it's something that's necessary if you need to have a closer look at the joints, for instance, if you're thinking there may be something going on, or if there's anything biologic you want to take a closer look at. Obviously, wisdom teeth, they're missing teeth, they might want implants, and that's when potential imaging might be required to make a complete diagnosis. So what I want you to think about now is I want you to assess the stability of the joint, and I'm going to take you on a little process or a little journey of how a joint can potentially break down. And so going back to the visualization of the joint yesterday, what I want you to visualize is that we, in health, start with a properly aligned condyle disc assembly. We have alignment where the disc is on the medial and the lateral pole, okay? And we have complete access to centric relation. The second possibility is you still have that good intact joint on the medial and lateral pole, but maybe there's a discrepancy between CR and MI. So in this situation, CR is not equal to maximum intercuspation. And because of that, you have a slightly hyperactive inferior belly. Now, just because you have this number 2 patient where there's a slide, there does not mean it needs treatment. But this is definitely going to be the case where I'm looking for that SOI, the signs of instability. All right, because if the slide exists and they fiddle with it, they could potentially get into trouble. So that's the number 2 patient. Number 1 and 2 both have great joints. The third possibility, and there's 2 parts to this, is you now may have disc movement. And in the first possibility, the disc is off the lateral pole. And as I said, because the medial pole is pinned down where all the pressure is, when you get a hyperactive superior belly, the lateral pole is often the one that comes first. And this is the patient that is intact on the medial pole, but that lateral pole may click on and off, or it might just be stuck out there. The lateral pole patient we can treat fairly normally because the medial pole patient is intact. So doing relatively normal occlusal therapy like equilibration and all is appropriate. We then move on, and now in this third type, we have the red, basically the red 3, where we progressed where we're off both poles. Now, this is when the patient is truly functioning on retrodiscal tissue and they get into trouble. They can have pain, and they then have the potential to progress to the type 4 patient where you have active degenerative joint disease. Now, what's important to remember is if there's a 4th 4, which is kind of a yellow 4, this DJD patient can develop almost like a flattened joint and a very flat condylar eminence that's bone to bone. And so you can go from something that is pretty unstable with active DJD, which is the red one, to something that starts to stabilize again. And that's something that we can determine with cone beam, and it's something we'll talk about in a little bit. Right now, I just want you to visualize these are the possibilities where patients can be. Number 1, 2, and 3A will not have pain in their joints. This one, where you're off the medial pole and you have active DJD, you will have pain in the joints, which means your history becomes extremely important. When you start having a displaced disc off the medial pole or DJD, you start seeing limited range of motion. So that's why we change range of motion, look for range of motion. If you're completely off the disc or have DJD, often they have pain unloading. So these are the things that we do to look at the joint carefully and to make sure that we don't miss that. So let's look at the 7 questions that we are going to ask, and we always start the history. And these are questions that in your preclinical interview, you could have an assistant or a treatment coordinator ask. It certainly can be asked by you as well, but I do think it's important that you review them, and anything that's positive, go over with them. So the first question that we ask, and again, it is related to the TMJ, is have you ever been diagnosed with a problem with either jaw joint? So point to the joint, tell them where it is, because people will kind of be pointing everywhere, but say, Mrs. Jones, right in front of your ear, you have this joint. This is where the hinge is. Have you ever been diagnosed or are you aware of a problem with either TMJ? And the answer is yes or no. Next question. Does your jaw joint, same place, does it pop, click, or make noise when you open, close, or chew? Yes or no? Number 3, in your joint, do you have pain or tenderness when you open, close, or chew? Number 4, have you ever locked, open, or closed? And I can tell you right now, if they answer no to those 4 questions, the likelihood of them having a TMJ problem almost goes to 0. But you can also learn and think about how the joints are changing a lot, and you can almost make your diagnosis from the history. So for instance, what if you say, Mrs. Jones, have you ever been diagnosed with a TMJ problem? And they go, yeah, this one, my last doctor said I have TMJ. And you go, does it pop or click? And you go, this clicks right here. Kapow, 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 making popping noises. And then the next question, does it hurt when you open, close, or chew? And she goes, no, there's no pain. Well, almost immediately you can visualize what's happening. This is a patient with a lateral pull click. Lateral pulls off, they click, and it's clicking on. Last dentist didn't really know the difference. He just knew it was clicking. He could hear it. He told them they had TMJ. But this is not a really significant problem. This is somebody we can often take through the things that we do. We'll talk about it with the splints and all in a second, but we've caught it before the medial pull slips off. You contrast that to the patient that says, yeah, I've got TMJ, yeah, it make noise, and yeah, it hurts right there. Now I'm thinking, ooh, gosh, we've got probably a medial pull problem. So all of my examination from here on out is going to basically confirm or negate what I'm visualizing, which is exactly why we spent time on anatomy yesterday. I want you to be able to visualize structurally what is going on based on what you're hearing or what you're evaluating with your work. Do you have frequent headaches? If so, how often? Be aware if they start pointing here, or if they say I've got sinus pain here, this is not where your sinuses are. If they say sinus is here, that could be sinus. But if they're talking about the back of their head or their neck or their face or their temporalis, they often aren't aware that headaches could be related to their occlusion. And so if they're having headaches, I'm going to be extra careful when I palpate the muscles to see if there's any indication. Do they clench or grind or ever been told that they do? And have you ever had trauma? So clenching and grinding is one thing they may be aware of, but if they've had trauma and they have pain, then I start thinking that maybe the trauma, particularly if they have a scarred chin, may be caused of that. We're going to look at range of motion, and we want to make sure the patient's opening at a minimum of 40 millimeters, and you want to make sure they're opening nice and straight. If they're opening a limited amount and deviating, remember the chin points to the affected joint. So if they're having pain over here and clicking over here and they open like this, I'm visualizing that disc is out in front of the condyle. So around 40 minimum protrusion, minimum of 8, left and right 8. And remember the chin points to the affected joint. We're going to load test. And so remember that load testing is about making sure that we can apply force into the joint without tension or tenderness. If they've had pain, have a history of pain, and you load test and it's painful, that's pretty much confirmation that the disc is displaced. If they've got pain and you can load it and maybe they have a little tension for a while and then it goes away, this could be just somebody with really hyperactive muscles. So load testing becomes a critical part of our diagnosis as well as verifying that we can get the centric relation. Doppler is something that we will go through with you in the hands-on, but it's just basically like a stethoscope on steroids. And what's cool about Doppler is we can listen to the medial and lateral pull. It is our way of assessing where the disc is. If the disc is in place on the medial pull and we listen to rotation and it's quiet, the medial pull's in alignment. If it's off it sounds crunchy and grindy. If we move in translation, that's listening more to the lateral pole. And here again, if it's quiet, we have an intact disc. So this is a wonderful tool. I think you'll ask Lenny and Raj about this. This is something that after you get used to this, is something you just can't not practice with, because it's so diagnostic and the patients can hear everything you're doing. Muscle palpation, again, in the hands-on, we'll go through with you, but we need to show you where the muscle attachments are from origin to insertion. We'll teach you how to palpate perpendicular to the muscles, but you need to be able to know what a normal muscle feels like and what a tense and spastic muscle feels like. And the good news is if we apply a couple of pounds of pressure to with our fingers, muscles that aren't active aren't sore, right? Muscles that are sore are being used for things other than just chewing and normal function. And the last thing, we're missing one here actually. Okay, I got it out of order. Let's do this one. I'll do it, go backwards. The sixth thing we're gonna do is look at the teeth for wear, mobility, and migration. And this should be our wheelhouse. The thing that I really want you to be assessing though, when I talk about wear, I'm not talking about half the tooth being gone, right? If you see facets on teeth, that shouldn't be there. If you can see dentin, that patient's lost a minimum of 2 millimeters of tooth structure, right? This is a sign of instability. Doesn't hurt. Patients aren't going to complain about it. Same thing with mobility. If you finally lose teeth, that often doesn't hurt, but that's a sign of instability that we have to show the patient. And certainly teeth that are just shifting position, whether they're getting crowding or spaces open up. And then the seventh thing, we'll assess whether we have to have any kind of need for imaging. And we'll talk about when we image when we get to the section on TMJ after the break. The other thing you're going to be doing in your exam is all the other regular dental stuff. So you're going to probe and take x-rays and look at the teeth and assess a nice little picture for you. But what you're going to start being able to visualize is the patients that you're going to be able to work in maximum cuspation and do everything normally, and then potentially have a conversation with the patient about getting some additional data. So to be clear, the complete examination is our way to uncover signs of instability and properly categorize our patients, green, yellow, or red. These patients, if we're going to really proceed with them beyond just biologic things and structural things, like with buildups and whatnot, really are going to need more data to be collected. And we'll talk about that. But if they're not ready for that, you can still do all the normal biologic things that you would do for them and get their mouth healthy from a periodontal standpoint and getting rid of caries and things like that. So categorizing these general and specialty patients is critical, and basically what we're doing is aligning the patient's problem with the correct workflow. So to be clear on that now, let's take a patient here that has some signs of instability, and maybe you've gone ahead and done your exam, maybe they even have had a prophy that day, and kind of what's next for them. Well, what you're not going to do is present them with a bunch of crowns. You don't have all the information yet. What we're going to be doing is talking to them about some of the things that you're seeing, and that it would be in their best interest if they came back and you did a more thorough evaluation, what we call advanced records. What I tell them is I'm concerned about their bite, whether it's the wear or whatever I've shown them. And our next step will be able to take some impressions and put their models on a device that will simulate their jaw movements. Today it's digitally, but that way we can start to assess where the damage forces are coming from, and we can start to come up with a treatment plan that would recommend not only getting their mouth healthy biologically, but also healthy functionally. And that way any dentistry we do for them going forward will last. So you want to charge a fee for this. It's going to be a separate visit. So you want to be doing advanced records on people who are ready, that want an answer, And that's why charging a little fee is important. Okay, so to me, to answer the question, what the heck is ready? To me, somebody who's ready is somebody who has signs of instability, who understands the problems enough that are willing to pay for advanced records to explore a solution. And so that becomes an important thing. I think that an appropriate fee for advanced records can be anywhere between $250 and $400. And that should include you gathering all the additional data, the photos, the models, mounting them, and creating a treatment plan. Now, when you start doing this, that's not going to be a very big fee for how much time you have involved with this. But here's the key. It will allow you to create complex treatment plans properly sequenced that are going to be successful. And this is the game changer in the Dawson process. This is the game changer of being able to study and be confident when you're sitting down with a patient. So we have all these different ways the patient can come in, right? We can have new patients that maybe see the doctor first. They could come in through hygiene. They might come in through an emergency exam. Maybe it's a meet and greet type patient. Showing our polls popping up right now.
Sorry, yeah, I got that fixed, I think.
Yeah, it's all popping up on my screen.
Is it gone?
Keep Xing. Get rid
There,
of all the,
okay.
it's still.
Can you X them out of your screen? Mine are gone.
Yeah, it's locked in my screen. All right, I'll just look around it. Okay, so bottom line is, you know, when we start doing these records, I lost my train of thought here. Okay, so basically we have 4 ways a patient can come in. The meet and greet by definition is just a patient who maybe is shopping a little bit. They might be looking for a fee. Sometimes we'll have them come in just to meet them, you know, and to give them a basic fee. Sometimes you have emergency exam, you have hygiene, you have new patients. New patients by definition is somebody that calls and says, look, I'm ready for veneers and I want to meet the doctor. Well, we just bring them right in for advanced records. So different ways people could come in. They're all going to get some sort of complete examination, and you have the possibility of drawing all of these towards the advanced records visit. And so to be clear, I want you to figure out or think in your mind how many advanced records you would want to do in a month, right? Or even a week. Because once you do this, you have to gather the data, you have to do a treatment plan, and then you have to sit down and have a consult. So I think initially a couple a month may be all you want to do. I can tell you in my practice, my goal is to just do 1 a day and 3 days a week. So I'm only looking at 12 advanced records visit a month, and that is a lot. If everybody would accept that treatment, I couldn't do it all. So don't just go back and just start doing models and photographs as much as you can, because you can't possibly have the time to treatment plan it. But in our advanced records, we're going to be doing a full mouth series of photographs. We're going to do mounted diagnostic cast, and we're going to do any additional dental any additional dental data that was not collected. So whatever that means, you know, maybe I wasn't completely happy with the probing, or I want to look at insufficient attached tissue, or any additional data that you need to make a good diagnosis. We mentioned earlier that we do the full series of photographs, and so taking these 21 photographs as part of our advanced records is important. And we'll train you how to do this. We'll teach you with a digital SLR, as well as the Shofu camera can be a good option. But what I'll tell you is, if you're gonna take these pictures, one of the best ways to get good pictures is to fire the dentist as the photographer. Train your team to help you with this. So, you know, a good assistant can be trained to do this in maybe 10 or 12 minutes. And they do it very systematically. They set the camera up the same way every time. And this is as important to me as my full mouth series of x-rays, because as I showed you in our smile design, from a diagnostic standpoint, it's really, really critical for what we do. We're going to make flawless diagnostic impressions. And so I would suggest considering, if you're not scanning, to move away from alginate and use a polyvinyl putty. These are 3M trays that work really, really nice. You can put a putty in there, like the Splash is a good one. There's a good putty out there from Haraeus, which is nice. Anyway, a lot of the putties are a little bit thicker, but essentially what we do is we put the putty in the tray. We can go ahead and make an indentation on it, and we'll seat it in the patient's mouth about 15 seconds. So it's, to be clear, it's not set up when we pull it out. And once you pull it out, all of this is still soft. The borders are still soft, and you can pinch that to extend it if need be. And then you can squirt a wash of the polyvinyl right into that, dry the teeth off, and stick it back in the patient's mouth. And what you will get is unbelievably properly extended impressions. So let this all set up at once, pull it out, border mold, and you will have all the critical structures that we need to be able to get that done, all right? And so good impressions are critical to what we do, because it's going to lead us to being able to get really crystal clear, proper impressions. And we'll talk about pouring here in a second, but we want to be able to have everything that we need to be able to see not only the teeth, but the free gingival margin all the way up to the height of the vestibule, the palatal areas, the retromolar areas. That's all important stuff. And yet, you know, I'm next to Bayview Dental Lab, and there's just so many impressions that come in that don't even capture the soft tissues. And the doctors are wanting to have a diagnostic wax up done. It's just not going to work. You got to have really good impressions. We're also going to do a face bow. If we're going to mount in an analog world, we'll do a face bow. We use the Slide-O-Matic face bow from Whitmix. I've used them all, and this is the one that I started with, and I keep going back to it because it's just so simple. The goal of a face bow is to do two things. It is to capture, however the maxilla is hanging in the patient's head, any sort of cant. We want to be able to transfer that directly to the instrument. The other thing the face bow does is it captures the distance from the incisal edge to the temporomandibular joint, or a very close approximation of it. And so if we can mount the maxilla on an articulator with that proper distance, if we mount the mandibular cast with a CR record, that means we can see the arc of closure and simulate the jaw movements on an instrument, which is what we want to do. So this is what the face bow looks like. It's got a bite fork. It's got some cotton rolls. It's got a transfer jig, the ear bow, and a couple of things here that work extremely well. But essentially what we're going to do is start by putting the little dot on the side of the nose. We're then going to go ahead and take the bite fork and put it between their teeth, and you can use a cotton roll to just stabilize it. So put that line on the bite fork in the patient's midline, facial midline, not the dental midline, but the facial midline. To stabilize that, then we can go ahead and slide the face bow right onto the bite fork. A little transfer jig goes right on there. Ask the patient to grab a hold of the ear bow, and they will guide it into their ears. And then we put the little infraorbital pointer on the little dot. That sets the vertical position of the face bow. And once that's there, we tighten down number 1. We then have a level on the face bow. We'll have the patient sit up nice and straight. And without taking out of their ears, we just level the face bow so that it's parallel with the earth. That parallels it with the top of the articulator. And that's pretty much it. I mean, that takes you basically about 90 seconds, and an assistant can totally do that. The doctor has to take the centric relation bite record. And so we're going to do this utilizing a Lucia jig. And let me just show you how we're going to do it. We start by using compound, and a Lucia jig is a little device that's like a deprogrammer. And so this makes it so much easier for us to take a record because we're going to be able to index this jig. But just take a little compound. You can also use bite registration if you like, but we're going to put that on the patient's teeth. And the most important a part of this is make sure that the lower incisal edges are perpendicular to the jig. If the lower incisors are real crowded, you could put some composite on them. You know, don't etch them, just some composite to level things. But notice how the compound grabs onto the adjacent teeth. Now, the next thing I'm going to do is do my bilateral manipulation. And this is when I'm going to go through my 3 increments of loading and make sure that they're programmed. So I have them slide around, go left and right, and kind of get everything relaxed. And now I can start doing my manipulation when I think he's there. And so I'm asking him if he's feeling any sign of tension or tenderness. And then I close him to the first point of contact. And so what I want you to visualize is he is arcing in centric relation. I'm holding him there, and we're going to mark that jig. And so when the lower incisor is on that mark, that is centric relation. That's where the lower jaw has closed in space on the arc to CR. So what I'm going to do next is I'm going to index that by taking a little bit of compound and going ahead and putting that right over the marks. Then again, holding the patient in centric and going through my loading, I'm going to arc the patient closed right into that. And then we're going to hit that with air. And this is the cool part. Once that's indexed, if the patient goes back into that position, well, he's in centric. And so you can take your hands off the patient now. And all we have to do is put wax in between the teeth. And so this is a beautiful wax from Whitmix. It's called the Danar wax. It is a little weird to work with, so we'll show you how it records, but you get this hot and it takes a little time to heat it, but the wax will absorb the heat, and then it becomes dead soft, and you have a long working time, which is great. The other benefit to it is when it gets hard, it is brittle hard. So when we chill it, it's rock hard, and the stone casts are only going to fit into this one way. So notice how we're heating both sides, and then we flip it over and heat up the other side. And then all we really have to do now is bring this to the mouth and put it between the teeth, and just make sure that when the patient closes, the lower incisor goes back in the index. This is capturing the maxillomandibular relationship in centric. Now, some of you are thinking, well, he's open, how could he be in centric? Well, remember, when the condyles are in centric, it can rotate. So you can take a CR record at multiple vertical dimensions, and if your maxillary cast is mounted with a face bow, it will arc back to the same point. And so remember, CR is, we have the ability to work at as much as 15 to 20 millimeters of vertical, and we can still be in centric relation on the arc. We then go ahead and trim this, and for a good record, we want to make sure we can put it back in the mouth. We want to make sure it doesn't rock, and we want to see what we call tooth wax tooth. And that is our way of making sure that we have all the earmarks of a good record. You can do it with a scissor, or you can do it on a cutting board like this with a knife. I find that the scissor just works out so beautifully. It's very efficient. We then put the record back in the mouth, and what we want to make sure is there's no rock, that he can close right into that, and that there's a precise fit in a tooth wax tooth. And at this point, we can chill this, and we have all the earmarks. Little bit of trimming, and then you can go ahead and store it back in the water. Last little check to make sure there's no rock, and that he goes right back in there, and that's the tooth wax tooth that we're looking for. So storing this in water becomes a good thing until you're going to use it. Now, the patient can be dismissed at that point. That's what the advanced records look like. We'll look at the digital option in a minute. But before you do your exam or your treatment plan, you've got to mount models. And this is what my son does in my practice. He runs kind of the MIDI lab. And so that person can be the person responsible for mounting the cast. And what's beautiful about this system, we have magnetic plates. The transfer jig will go right into this little table. And then we're basically going to just put the maxillary cast right onto the bite fork. We can mix some stone. The cast goes in there, and you basically just put a little stone on the cast, a little bit of stone on the magnetic mounting plate, and then you just close the articulator. The pin is at 0 here, and you close the articulator and let that set up. Again, we've taken the centric bite record as the way we've shown you, but that bite record then will go on lower. So visualize what we're doing here. The articulator is upside down. The bite record is between the upper and lower cast. We've used some wire and a hot glue gun to hold everything together, and we're just going to put stone between the two. And so this just works. And from there, we can go ahead and just analyze our cast and centric relation. And again, spend some time making these beautiful. Let the patient see something that looks really nice and not sloppy. If they see sloppy models, they're going to kind of think you're a sloppy dentist. So have your assistant, or in my case, my son, will sandpaper and make them nice and clean. Now, we had a question about taking a bite on a denture patient, centric bite on a denture patient. And the biggest problem with a denture patient is the fact that if you're using bite rims, wax rims, and record bases, that the record bases move. This is what a central bearing point is. We're using a record base. We've got 2 teeth on this. You'll see the upper teeth have been set, so we're kind of verifying tooth position and vertical. But to take our final centric, there's a little piece of plastic that goes across the wax rim on the bottom, and this piece here can be screwed up and down. This is not like a screw. This is like a ball burnisher. Now let's watch what we do, because the upper denture has a plastic, like a plastic piece that's in the palate. And so this is clicking on locators, but the upper is a denture. But watch what we do. So when we put this upper denture in, notice that that is got a black mark on it, just with a Sharpie. And what we're going to do is, when that little pin seats the denture, the record bases don't move. This can work on upper and lower dentures just as easily. We're now going to take the patient using our bilateral through our border movements. And what you're going to find is, when you pull this out, there'll be a pinpoint, like what looks like a arrow point, and the tip of the spear is where centric is. So we'll take that out and then just have a look at where we are. It really is cool. That little point is centric, and we're going to basically draw a line right there, right on that spot, or make a little hole right there. And so when we put it back in, the pin can fall into that little hole. That's where centric is. and then we'll just squirt bite registration between the bases, and it all comes out in one piece. That works really, really good. So let's talk a little digital in the remaining time here before we take our next break. And what I want you to think about here is, in our transition to digital, we've had some false starts. This has been a dream of mine for probably a decade. I've been doing CBCTs for 10 years. I started with Sirona probably 15 years ago, then went to A4D and then came back. I've worked with Invisalign, and nobody could really understand what we were trying to do. Everybody could make restorations and kind of create an on-layer, a crown or something like that. But really doing CR-based treatment planning on a virtual instrument was just not possible. And so we see 3Shapes entering the picture, and it's been amazing. We got to give Lee Culp. He's a certified dental technician in Raleigh. I've known Lee forever. He's had a big impact. Ian Buckle, who is in the UK, Drew Cobb and Drew Reingold, who are here in the US, have all been working hard on this. Drew hasn't been, Reingold hasn't been as involved with the 3Shapes, but amazing with Mesh Mixer and all the different things. So these are the people, along with myself, in terms of really spearheading what it is we're trying to do. What I want you to see is we definitely have the ability to mount models on a virtual instrument, and everything that we would do normally in terms of being able to see the condylar guidance, the anterior guidance, seeing slides between CR and MI are all completely possible, and we are doing that now. What is amazing, though, is how fast we can be on an articulator. So how do we do it? I mean, what is done? And the first thing is you're going to be scanning. This is Kristen, my primary dental assistant. She can scan the upper and lower arches with iTero. She has little races. I think her fastest upper and lower scan is like 1:40, which is incredible when you think about that. That I can have something that, whether we're scanning in CR and MI, that I can see it that fast. Again, we're going to scan a buccal bite in centric relation, and we're going to utilize the exact same technique, but no wax. What does that mean? It means I'll still index a Lucia jig exactly the same way, but I don't have to have wax in there, all right? What she'll do is she'll scan the upper and lower arches, put the Lucia jig in, and then scan the space between the upper and lower arches. This locks in that relationship. Now, when we bring our scans into the to 3Shapes, that upper and lower scan, or that upper and lower alignment in centric relation, is carried in, and that's what's so slick about it. So again, scanning the arches first, then scanning the relationship in CR is next. And what again is cool with the iTero is that I can instantly see that. So when I look at it, I can look at it in centric relation, and I can see where the interferences are in centric relation. But to be clear, I can't do anything with that. I can just see the interferences, which is, again, great documentation. Now, if I want to mount this, what we will essentially do is take it into 3Shapes. And so Kristen will be doing this part. My son will be waiting in the wings, and so this is what he's going to do. Now, if we want to do more advanced mounting, we'll talk about Bellis in a second for a virtual face bow. So let's look at virtual mounting. Well, with a virtual mount, what Cornell will do is he will go into 3Shapes. He will grab the scans off of the web that are in the cloud from our iTero. And the first thing he does is put the maxilla on this little platform. This basically creates an arbitrary face bow that we'll see in a second. The mandibular cast is already aligned in CR because we scanned it like that. And he has it on an articulator in about 10 minutes. I can see the slides. I can open and close the vertical. I can do any of the excursive movements that I need, okay? So that's really, really cool. Now, this is a guy that you'll see in a second has a lot of wear and tear. Now, if he gets that mounted for me, what is going to be the next thing that I do? Well, when it comes time for me to do my workup, I'm going to do my 2D analysis exactly the same. This is actually the case I'm prepping Thursday. I was supposed to prep it 2 months ago, but we're finally getting to it Thursday as I go back to work. I'm excited about this one because it's a really cool case. But we're going to, in the wizard, do our 2D analysis. So you can see his teeth are short, tremendous amount of erosion and wear on the back sides of his teeth. So I'm going to basically figure out how much length I'm going to add, which is I want to do about 1 to 2 millimeters. I'm going to bring him out slightly. Buccal corridors look fine. Doesn't really have a high smile. He has a little bit of gingival irregularity that I'm going to fix with the laser. Looking at my golden proportion, it looks pretty good. I'm adding 1.5 millimeters there, bringing the tissues up on the central. My papillas look fine. Axial inclinations look fine. All the things in the wizard and my embrasures, the patient wants deeper, more youthful embrasures. But when I hit my imaging button, I have my 2 shapes of where I'm going. I can now take this to the digital world. And so let's look at how this works. So here's my mounting, and I'm visualizing that I want to do resin on these lowers. We need to idealize my incisal edge position. So what I want you to think about is when these teeth come in, they're almost like denture teeth that will go right through the teeth. And so what's cool here is how instead of waxing, I'm literally doing this just digitally. I'm just taking the new tooth and just adding back what's missing to idealize my lower incisal plane. So now we're on the upper incisal plane and facial contour. Again, I'm bringing in the tooth size that I want. It all comes in one arch. And the first thing I'm going to do is get my facial contour and incisal edge where I want it. I can make very precise measurements here. If I get one central right, I can go ahead and duplicate that and bring it to the other tooth. That's what you're going to see here. I'm going to get that one central how I want it, bring it over, then copy it, and then flip it over to the other tooth, and then get it in position. So we can go tooth by tooth and get all my facial contours exactly what I want it. Now I'm going to go to vertical and equal intensity stops. Well, notice how I can open the pin. I know he has wear, so I'm going to open the pin about 2 millimeters and have a look, just like I would in an articulator. And then I can start doing some waxing if I want. So I lock the pin down at 2. I can get rid of the lower, and then I can start to see what I'm going to do, where my contacts are. So literally I can just grab the teeth. Instead of waxing, I can just warp the tooth until I start seeing things come into occlusion. Guys, this is ridiculously fun to do. And if you understand these principles, it works so beautifully. Dr. Dawson used to say, if you try to do digital in the absence of good principles, you'll just screw up mouse faster. And I agree with that. But if you apply the 5 requirements to this digital workflow, this is CR-based, anterior guidance-based dentistry, which really, really is cool. Now, what about equilibration? Let's go back to this case. And again, I showed you the hit and slide that exists here and how you can see the interferences. But how do we make determinations? This is the same case in 3 shape. And notice what we can do is when we close a case down, what's happening is the teeth are actually just going through themselves back here. And I'm going to have them pass through one another until the front teeth come into contact. When you're looking back here, what you're actually seeing is how much tooth structure is penetrating through. That's how much you would have to grind away. And in this second molar, you can see I'm almost taking the entire cusp away. I know in seconds that I can't equilibrate that this is going to have to be an orthodontic case. Now, if you want to do a trial equilibration, you can still do that, but it's allowing us to do things faster and more rapidly, and I think just better. Now, what I mentioned is the maxillary cast is mounted with what we call a arbitrary face bow based on the Bonwell point. And again, this was interesting research that basically showed that they compared the ear bow with a Coyce face bow. Coyce face bow is based on the Bonwell point, which is basically setting the maxillary incisal edge 100 millimeters from the joint, which is an average. Well, you got to remember, ear bows are still somewhat of an average. And when they compared the ear bow with the Coyce face bow, the amount of difference between one and the other was pretty similar. So is 100 millimeters good enough? Is this arbitrary face bow, this Bonwell point, good enough? It's incredible to go and look that Dr. Bonwell described this in 1864. So 100 millimeter distance based on the Bonwell triangle has been around a long time. What I can tell you is for my nuts and bolts everyday cases where it's just a little bit of equilibration, maybe we're not opening vertical dimension, this works out pretty well. You can mount the maxillary cast utilizing the Bonwell point. Again, when you scan in centric, the mandibular cast is going to come in whatever buccal pipe you shoot. So if you're scanning in centric, it comes in centric relation. And again, your casts are going to be mounted very accurately. And the best part is no wax, okay? No wax in this game. And again, I've just seen a lot of inaccuracies by wax warping or wax breaking or dentists not trimming the wax right. So this is something that we're going to have to teach you both ways, but I'm hopeful that this is well in the way. Now, what if you want to go to another level and you want to have a precise face bow? Well, there's something called Bellis HD that we are utilizing that, again, is a way to scan somebody's face. We do it in about 15 seconds, but the patient just follows this. They're doing a big smile while they do this. And essentially what you're doing is aligning where the teeth actually are to the whole face in a three-dimensional picture. So here again, in a matter of minutes, you have something that you're looking at, and you end up kind of with this creepy 3D rendering that you can then look at their face and see all the components. So we can actually attach the intraoral scans to that and bring everything in as one picture. So when we go back to our three shapes, we can see the face, the teeth, and then basically align the articulator right over the condyles, which are right in front of the ear. So this becomes a very, very quick and easy way for us to work. And so you can see this is some of the work that Lee's doing, where he's, again, looking at provisionals. He can also transfer and look at the preps. You know, Pete used to say that articulators don't have lips. They kind of do now. And I think this is going to get more and more accurate. So just to finish up, you know, being able to take scans, this is some of Drew's work that's actually from the, not the iTero, but the three-shape scanner, and being able to choose vertical dimension, to be able to do a precise workup, choose the kind of teeth that you'd like to bring in, and design accordingly. It's pretty fun. It's pretty cool. If you're used to utilizing digital at all, like I went to it very quickly because I was used to using E4D in CERAC. And so the tools may take a little bit of time to manipulate if you're not used to that. But what we want to be able to do is be able to do some sort of pre-op mounting in centric, do some sort of visualization. We can create a diagnostic wax up that can be printed for you to be able to make provisionals. You can even go right to some sort of shell if you want. terms of places to learn this, certainly Lee Culp is a great resource. We do have a digital class in the advanced curriculum that's taught by Lee and myself that I think is going to get very hot based on the interest in this. And then Drew Reingold has been an invaluable resource. I can tell you we will be having him doing things, probably one-day classes that will be available. Watch our Instagram, watch my Instagram. We'll be posting about it. But you know, we want you to be able to see what he's doing both in a orthodontic realm with clear aligners, but also some of the things you can do right there in house. We had Drew actually come to the office and train my team. And again, just showing you that, you know, you never stop learning this stuff. This is my office, my team, helping us transition to digital. So I can't say enough about Drew Reingold. He is one of the absolute rising stars. He's also involved in the study club with Raj there in New Jersey. And keep an eye on this young man. He's got a big career ahead of him with what he's doing. I think he's forgotten more about digital maybe than I'll ever know, but that's kind of how that is. All right, so that was a lot, but let's, we're right at 1:30, right on the money. So let's do a little Q&A, maybe start with the poll questions and go from there. I'll see if new poll questions come up. Good. All right, number one, the complete evaluation of the mastory system is the only way to properly categorize your patient's green, yellow, red. Coming in fast.
And doesn't seem to be much debate on this one.
Yeah, I mean, 91%. The answer is true. And again, remember, you don't categorize your patients by the records. That's what people get confused by. We make 100% our categorization by doing the exam. And that's what you need to really be implementing first is that examination into your practice. All right.
Okay, next one.
Mounted diagnostic casts are always part of a complete exam.
I'm glad you put this one in here. All right, we have
about 50-50 on this one. So yeah, you can lock that down. So I want to be really clear about this because this is what I think when you hear this section, this is what always gets missed. And I want to be really clear about it. We do the exam on everybody. We only do mounted cast when we are dealing with people that have specialty problems. So the mounted cast is not part of a complete examination. A complete examination is what we do in evaluating the patient, looking at their mouth, looking for signs of instability, looking for periodontalgy, looking for caries, looking for structural problems on teeth. The mounted casts are part of advanced records. Okay, it's a separate thing. And we're only going to go to advanced records when the patient has signs of instability and they are ready.
okay. Let's find the next one. Here you go.
The advanced records visit will include mounted diagnostic cast, analog or digital, a full series of photographs, a CBC when appropriate, the gathering of additional information needed for complete diagnosis, all the above. All right, I may be 100 on this one. There you go. There you go. Okay, so that's advanced records. So that's great. That's what you need to remember. The difference between the complete exam and the advanced records. And then one more, Joan. True or false?
Let me find it. Whoops, wait a minute. I hit the wrong one. Okay.
It is now possible to do the entire 3D diagnostic workup in the digital environment. This is relatively new development.
All right, here we go.
Very good. So yeah, that's true. I will say what might throw you is that some people that are out there digital might not feel like this is a new development because digital's been around a long time. But I do think really working in centric relation and being able to employ occlusal design the way we're doing it is relatively new. You probably ask Lee, he feels like he's been doing it for a long time, Lee Culp, but again, in a way that we can do it relatively efficiently, I'd say it's a pretty new development.
All right, now, I just want to let everybody know that we now have Dr. Steve Horde also helping us answer questions. Dr. Horde's one of our teaching assistants from New Bern, North Carolina. So we've answered 402 so far. We have 35 open. We're answering as fast as we can. So let's see what we got here. How do you determine what the appropriate amount protrusive occlusion is on the maxillary veneers? I know CR equals MI occlusion is not recommended on the margins.
Yeah, so it's the exact same process I showed you yesterday. You're going to follow the rules we went through to establish anterior guidance. So the first thing you're going to do is check for a long centric to see how much concavity you need. And then if you have enough room for envelope of function, then it's just developing a smooth protrusive path. And again, don't worry about the fact that there's going to be lines on your veneer because it will transition from enamel onto the lingual surface of the veneers. But that's okay. As long as it's in harmony with envelope of function, you'll be good. And you're getting posterior disclusion.
Okay. Will equilibrating alone solve a TMJ issue if caught when it's asymptomatic lateral pole click pop?
So great question. So what we feel like is if we can fulfill the 5 requirements of occlusal stability on a lateral pole, it should prevent it from getting worse. All right. So the main thing is we do visualize that the lateral discal ligament is loosened. So equilibration is not going to tighten that back up, and so the patient still may have a click. So we can't promise that the click will go away. But what our hopes is by getting the muscle activity lower, that this won't progress to a medial pole problem, which would be symptomatic. That would be the reason to treat that patient.
Okay. When you ask your 7 questions, what if they have a history of fibromyalgia?
You know, it's interesting. People with fibromyalgia are usually not very shy about that. So when you start getting into the questions about headaches and things like that, you're usually going to get some positive responses. And so, you know, those type of questions can also be in your regular health history if you want to ask those questions. But I still feel like people with fibromyalgia can still definitely be helped. I just might be also be utilizing a physical therapist along with what we do. The way to think about a fibromyalgia patient is it's almost like their resistance is lowered. So they're more likely to, little occlusal problems can cause profound problems for them.
Okay. Is a patient categorized differently if he is clicking or popping on closing versus opening?
No. Usually you're going to have a reciprocal click. You might not hear it, but it's going to always click on opening and it's always going to click off on closing. It's just that depending on how intact the posterior leg band is, and we're going to get into this in a little bit. Yeah, we're going to get into this in a little bit. So that's the next section. I got them right where I want them.
Okay. Can you go over again how to differentiate between a lateral pole problem or a medial pole problem?
Another one that I'll do next time. Yeah, we'll talk about that.
In the next section?
Next,
okay.
We're going to do TMJ dysfunction next.
Okay. How do you take a protrusive bite record as it hasn't been mentioned here?
Yeah, so it's pretty easy. If you want to have, and we get into this a little bit in a treatment planning class, but if you want to take a protrusive bite, in the records class, if you want to take a protrusive bite, you just have the patient protrude approximately 5 millimeters forward and take a wax record there. Similarly, you can do something similar scan-wise and take a second bite and scan that if you want to set it.
Okay. Kelly Verber, your Bennett and condylar angles were set to 10 and 34 on your digital articulator. Can you talk about these settings?
Wow, listen to her.
Yeah.
So, yeah, that video was actually a stock setting. So I on my virtual articulator will pretty much set it like we set the combis, and we put them at 15 Bennett and 20 when we go into straight protrusive. And again, that instrumentation is going a little bit beyond this class right now, but what we're trying to do is set an instrument up so that if we design restorations on the articulator, we're just going to get disclusion faster in the mouth. And one thing about setting the condylar axis guidance at 20 and the Bennett at 15 is that's always going to create more opportunity for disclusion in the mouth. In other words, if we can make it disclude on the articulator, it's only going to disclude faster in the mouth. Why? Because the condylar guidance is always going to be steeper and the Bennett angle is always going to be less.
Okay, let's do one more and then we'll take a break. I foresee a lot of patients who have signs of instability, but do not want to pay for advanced records or really want to explore. How do you overcome those barriers, or do you just restore an MI until they're ready?
I don't restore an MI. I don't. I mean, I'll take care of biologic problems. What I would really suggest is if you're having a lot of resistance, I would utilize photography a little bit more. I'd make sure that you're spending enough time explaining people what's going on. And I would also find out what the barrier is. And that's not to say 100% of my patients go to records. There's some patients that when I find out why, I very rarely find out that the patient don't want to go to records because they don't want to be healthy. They usually don't want to go to records because they can't afford it, or they're busy, or these other things. And sometimes we have to have patients have something catastrophic happen. So, but if I sit there and say, you need to do this before you do crowns because we can't kind of get the bite right, and then they won't do it, so we just do the crowns anyway. Well, I don't know what sort of message that's sending to the patient as well as my team and everything else. I mean, there's got to be some sort of line in the sand. And so, and the other thing is you also have to kind of think about how involved is this patient. If it's just a little bit of sign of instability, then you feel like you can monitor and the person needs one crown, that might be different than the person who needs multiple. But in my practice, generally speaking, if they have signs of instability, I won't do prosthodontics on them unless we've solved the occlusal problem. And I can tell you why. It's because early in my career, I did that, and it always comes back to bite you. The patient's going to have problems, and you end up redoing dentistry and then equilibrating and doing a bunch of stuff for free anyway. So I just think that maybe a little bit more time to explain why they need records. And we're going to have David Rice talk about this in implementation, but connecting with patients and making them understand another level, I think is clear, is key. 5 minutes, Joan?
Okay, 5 minutes. We'll keep typing answers for you.
Perfect. Okay, so one last requirement, and that is to talk a little bit about TMD. And again, a lot of questions about kind of what's happening at the disc level. And so I want to kind of end a little bit talking about understanding how joints break down at another level, and then finish with splints, because like the exam, doing the comprehensive exam, not necessarily records, but doing that complete exam and adding the TMJ occlusal exam to your repertoire, and also knowing how to do splints is a great place to start with us. And as you train and go through the rest of the curriculum, we will put the missing pieces of the puzzle together for you. So again, our thought process for TMD, we want to ask ourselves, is the patient symptomatic? Are the symptoms due to muscles? That's one of the things we want to really make sure is differentiate between muscular problems versus problems in the joint. is there a disc displacement, and is the disc displacement a partial disc displacement like a lateral pull, or do we have a complete disc displacement that involves both the lateral and medial pull? So, as we understand disc derangements, we have to make some sort of differential diagnosis of the TMD issues that patients have. So the first thing that I want you to wrap your head around is this concept of what we're going to call occlusal muscle problems. And that's a patient that may have an interference lacking the five requirements of instability, may be able to rub on back teeth a little bit, but in the process, the teeth don't really get damaged, the joints don't get damaged, but the muscles get sore. And that's what we call occlusal muscle problems or occlusal muscle pain. It is definitely the most common issue. It is 90% of what TMD patients are. I mean, most of the patients that you come in that say, I have TMJ, you're probably going to find that the joints are fine and the muscles hurt. And that's great because they're the easiest ones to fix. A complete exam is going to be needed to screen this. We've taught you how to do that. We'll talk to you a little bit about what we call the clench test. And probably the best test you can give them is the anterior deprogramming test, which is if you put a Lucia jig between their teeth or an NTI, one of my deprogrammers, a Coist deprogrammer, whatever, if you put anything between their teeth and separate their back teeth, if their muscle pain goes away, then they have occlusal muscle. Now, the other great thing is if you have a patient with a displaced disc, fully displaced disc, and you put an anterior deprogrammer in, it often makes it hurt worse. So one of the best things we can do if you're trying to figure out whether it is an internal derangement or a muscle problem is the anterior deprogramming test. With an intracapsular disorder, again, you need to do your complete exam for screening and your preliminary diagnosis. You want to figure out where the disc is on the medial lateral pull. This is done easily, or the most easiest way is with just listening to the history as well as with a Doppler. And again, the treatment of the intracapsular disorder is going to be specific to the TMJ classification. So when we start looking at ways to evaluate whether the joints are healthy, notice that we've already taught you the screening history, we've already taught you load testing, we've already taught you range of motion and path of motion.
John, I think you might have locked up.
My computer's not locked, it's just locked on.
Okay, there you go. Now we can hear you again.
Okay, is that good?
You were just,
right.
Yeah, there we go.
Okay, all right. That's kind of crazy. All right, so let's go back and just, again, this is weird, I'm losing, there we go. Okay, so we've taught you all these things. The anterior deprogramming test is probably the one that is the most important as we move forward. So when we start looking at intracapsular disorders, here again, the complete exam is going to be key, knowing where the disc is, and we're always going to aim our treatment at the specific TMJ classification that we're after. So here again, this is the one that we have trained you on, is everything here but the anterior bite plane. So again, screening history, load testing, range of motion, Doppler, and imaging should be fairly familiar from doing our regular exam, but we're going to go into the deprogrammer in a little bit more detail. So here's important from the standpoint of looking at load testing. If load testing produces any sign of tension or tenderness, and we're just going to talk about this part of the exam, it is either going to be an occlusal muscle disorder, okay? And what I want you to visualize is if you're load testing and the condyle isn't quite seated and you are applying pressure and it creates discomfort or maybe tension in this area, that's we're visualizing the lateral pole, the lateral pterygoid is getting stretched. It's just not completely seated. The muscle hasn't completely released. If, however, your load testing produces more of a tenderness type situation, then we're dealing with some sort of intracapsular disorder. And that might be related to highly inflamed retrodiscal tissue, or it could be some sort of bony breakdown. So visualize two types of intracapsular disorders, which are fairly common in terms of once you've got something going on inside the joint. You're going to have disc derangements, which are most common, and then you're going to have some sort of bony pathology that we're going to call DJD. And so once you have DJD, this DJD can either be active, where the condyle is actively breaking down, or it can become inactive, where the condyle is starting to stabilize. And so to be clear, if we get to this point where a DJD, we're trying to get them to an inactive situation where we can then start to do stuff to their teeth. Now, we used to say that this was less than 5%. I can tell you since cone beam, we find more than that. And so I think probably realistically, when you start having active breakdown, you're probably looking at maybe 15% of the population of people that have internal derangements. So if you think about facial pain that's related to what we do, 90% is going to be muscle, 10% is going to be intracapsular, and of those intracapsular problems, 15% are going to be when the condyle is actively breaking down. I see a lot of these patients because they find me, but in a general practice, they're not going to be that common. You're going to see way more muscle. But here's the deal. For either problem, when you have an intracapsular problem, this is now a red joint, as we've taught you, you have to fix the problem before you start working on the teeth. And what I mean by fixing the problem, stabilizing that joint, getting that joint nice and stable. So when we hear a clicking joint, what's happening? Visualize that when we click, we're always clicking on opening. So visualize that as we close, it always clicks off. So on closure, the disc is going to click off. And when you open, it clicks back on. And when we close, clicks back off. And that's what's going on. Whether it's medially or laterally or both, then that's what's happening. You know, why do discs click? Well, you're going to get clicking joints because of muscle hyperactivity that's loading the joint, muscle activity that's pulling the disc forward. They are patients that the weak link in the system is being caused by that. So if muscle hyperactivity is the thing that is causing the disc to become pulled forward, and if muscle hyperactivity is the thing that seats the joint, you know, what's the big question is, what causes this tension to the muscle? And you know this answer, because it's the same thing that causes the increased muscle activity that breaks teeth down and get muscle sore. And that is that you are always going to have some sort of occlusal interference involved. As you think about the superior lateral pterygoid, this muscle is always involved when a disc is deranged. It is the only thing that pulls the disc in this direction, okay? And if you have a discrepancy between CR and MI and the patient's clenching, the condyle is being pulled by the elevator muscles in this direction. So it's no wonder that the structure in between, which happens to be the disc, starts to get nailed. So occlusal interferences are the trigger for most, occlusal interferences are the trigger for muscle incoordination of the mastory muscles. And so because of that, joint loading, most of the TMJ problems are related to the same thing. Now, you can certainly have joint dysfunction because of trauma, right? A blow to the joint. And we also know that there are secondary factors that we've talked about, like certain hormones, like low estrogen seems to affect it. But let's have a better understanding of anatomy, and let's look at some of Erickson's videos that I really think help us understand how the condyle functions when we rotate and translate. Now, what I want you to see structurally, here's condyle, here's articular eminence, this is the glenoid fossa. Look at this big biconcave disc. This is the foot of the disc, this is the posterior band, and we've got muscle. And watch how this thing opens and closes, how that condyle basically self-centers that disc. A lot of the drawings that I saw that you sent me, the discs look like little watermelon seeds stuck on top of the condyle. And so I really want you to visualize the shape, the hourglass shape of this disc in health, okay? So let's progress this a little bit, and now let's take a disc that's clicking, and it's clicking off the lateral pole, right? So now, again, looking at our anatomy here, you can see the disc slightly stuck forward. We're looking at the lateral pole here, and watch how the disc basically slips back into position. As we open, and as we close, we're going to see it click off. That's a early type disc displacement. If we look at our friends from BiteFX and see what that looks like, we can see that here again, the disc is off, it clicks on opening. Now, this is actually one that's stuck out there. So this is actually a closed lock. So if the disc stopped clicking, you kind of see this, but the medial pole is still intact. You might have a little deviation because of clicking. It tends to deviate towards the side where the disc is off and then kind of shoot back to the center when it recaptures. So that's normal. Now let's take the disc off and watch how it clicks on. So that's the kind of deviation that you sometimes can see. When the medial pole gets involved, there's usually more destruction. Things might be a little bit flatter. And here's one showing a disc that's just stuck out there. It's not recapturing. So the disc is way out here. And notice the patient is just kind of sliding. You've lost joint space. This is retrodiscal tissue. If that's inflamed, this is going to hurt. If it's fibrotic, the pain can be not as much, but notice how everything's getting flatter. So again, if we visualize medial pole changes, this is now a situation where the disc is completely displaced. And some of the issues that go along with that. So now this is DJD, this is end stage. And again, what I want you to visualize is degenerative joint changes will go through active stages. When this is going on, when it's breaking down, the occlusion is going to be settling back. And what we're trying to do is get to the patient point where the bone is eburnated and flat. And this bone-to-bone contact can actually be fairly stable and fairly functional. And we'll know that in splint therapy because the splint will be changing when it's actively breaking down, always hitting in the back, and we keep leveling the appliance. But when we get to the point where we're stable, then we stop seeing changes in the splint. And that's when we know we've gotten to adapted centric posture. So if we have active DJD, looking at the condyles here, what I want you to, again, visualize it. What I want you to visualize is the changes in the occlusion that we'll see. Disc displaces. We then will get some sort of perforation through. And we start getting flattening. And this is sort of what starts to go on. If it's allowed to continue, then what will start to develop is an open bite because the condyle is seating. We'll develop an open bite. The condyle will be seating. Sorry, I did that one before this one. So you see the open bite, and as that starts to function and flatten out, this can potentially get worse. And of course, see how the condyle's changing, see how the eminence is flattening. The bone to bone, you'll see this on Panorexes. It just looks like the condyle's been in a belt sander, and it's not common, or it's not uncommon when this occurs that you start to see an open bite develop. There's certainly a progressive possibility of this. This is what we always see. I would say a progressive probability that as the joints break down, think about the jaws always becoming more class 2 and definitely developing more of a definitive class 2 type situation. Open bite, posterior interferences start coming into play, more joint load, more breakdown. So we start thinking about imaging of this. Certainly MRI is a possibility. CBCTs are also a possibility. I look at CBCT as my go-to because I have the ability to do it in the office, and it's such a great screening film. If you want to know where the disc is specifically, and if I've got something that's going on at a disc level that I just can't figure out, then I may ramp up my imaging. But again, getting radiology report on MRIs and CBCTs, I think, is very necessary for medical legal reasons. So I get all of these read. As we look at our reasons for imaging, all these things come into play. Particularly, things regarding any type of worry about pain in and around the joint, I always get an image. If I've got a patient in a splint that it's just not going well, I get an image. Changes to the bite, growth changes, anything that kind of makes you nervous a little bit, and there you want to see specifically what's going on, then I think a CBCT is the place to start. And this is a great slide because it shows us. Again, you can see where I would start with in terms of CBCT and the times that we would recommend getting an MRI so we can see soft tissue. Generally speaking, if we want to see osseous contours and morphology, we think about CBCT. If we want to see specifically where the disc is, then we are absolutely going to be aiming our attention more at the MRI itself. So again, looking at the MRI, again, I've spent some time with radiologists and they've taught me all these structures. It's strange because really dense bone is black. It's the opposite of what you'd think. But basically what they're doing is they are going to mark these areas, and then they can determine where the disc is. What's cool is they can also look at the disc on the medial and lateral pole. Still, with regards to bony pathology, CBCT is the way, and it's so easy. If you've got a specialist that's got a cone beam, they can help you with this. We can certainly see early changes in the condyle, early changes in DJD, and we can pick up things like condylar fracture like we've got going on in this joint here. We can pick up things that are osteochondromas and all sorts of things. This is a great reference if you have interest. Again, Hatcher and Tamima is the authors of this book, and I mentioned David Hatcher yesterday. We had him at our alumni meeting, and he is phenomenal. They own a company called Beam Readers, and this is the gold standard. If you want a cone beam read, they are reading thousands of joint films a week. And again, your maxillofacial radiologist or your radiologist at the hospital just doesn't have the expertise to diagnostically assess what we're talking about here. All right, with that now, let's talk about precision orthotic therapy. And I want to spend a little time talking about splints, and then we'll do a Q&A, and then we're going to get David in here to talk about implementation. So again, there's a zillion different types of splints, and splints are basically for one thing, to make a definitive diagnosis to determine this. If we work on the occlusion in a reversible way, can we have a positive effect and reduce the symptoms, right? Because I don't want to necessarily have the patient with a splint the rest of their life. But if I can create an occlusion that helps the patient, then I ought to be able to create an occlusion with their teeth that does the same thing. So for me, anybody with pain in and around their jaw, I'm always going to do a phase 1 treatment first to make sure I can do it in a reversible way. And if I can, it helps me make a diagnosis that I can then do dentistry on them. Some of the differential diagnostic techniques we have are things that can just separate the teeth. Deprogrammers of any kind, Dr. Dawson would put cotton rolls between the teeth. We have aqualizers, Lucia jigs, NTIs. I'll show you what a quick splint is and a B splint. But all of these here, basically the Lucia jig, NTI, quick splint, B splint, these are all midpoint anterior contact appliances that separate the back teeth. And I want to be really clear about this. These will decrease muscle activity, but they will increase loading to the joint. So deprogrammers will help you make a differential diagnosis. If you put a deprogrammer like this in and the muscle pain goes away, great, you've made a diagnosis, it's occlusal muscle. But if you put one of these things in, always tell the patient, you've got about a 90% chance this is going to make you feel better. But if you hurt worse right here, take it out and call me, because you probably have somebody with a displaced disc. Now, NTIs and Lucia jigs and B splints, particularly B splints, have sort of a lab component to it. What I love about these quick splints is this is a fairly inexpensive way to make a deprogrammer, and I use them on patients that I might have a really tight muscles and I just want to deprogram overnight to help get me to centric. Or it might be somebody that I just want to send home to see if the muscle pain goes away. Great little kit. It just has a stock little U-shaped, semi-U-shaped deprogrammer. You put the the registration material in there and stick it over the teeth, and it separates the back teeth. You could do the same thing with a Lucia jig or an NTI. Lucia jigs, be a little careful. NTIs too. I worry about people sleeping in those things because I worry about aspiration or people swallowing them. What you have to know about deprogrammers is when you separate the back teeth, if people abuse these things, back teeth will erupt. So remember, a long-term use of any appliance that just covers some of the teeth can create occlusal changes. If you want to have fun, Google NTI, anterior open bite, and you'll see picture after picture of people who have worn NTIs too long for too many hours of the day, back teeth extrude, and you end up with an open bite. Not only that, you're also getting the lateral pterygoid to release, so condyles are seeding a little bit. So we've got to be careful of those things. Let's look at the types of splints that we use, and let's make this really simple. So we're going to have both permissive splints. Now, permissive splint, I would call a splint that permits the condyles to centric relation. And so a permissive splint or adapted centric posture, but a permissive splint permits the condyles to seat. And we can have certainly sectional anterior deprogrammers, we can have dual arch B splints, and we're going to talk about the superior repositioning splint. The other possibility is a directive splint, and a directive splint is a splint that directs the jaw away from centric relation, or adapted centric posture, which we utilize very rarely, but I'll tell you when. So let's look at the sectional anterior deprogrammers and look at the the different options. Again, this is an NTI. It is great, used great for in the diagnosis of muscle versus intercapsular problems, as we talked about. It will decrease muscle activity by as much as 80%. When this is in, people cannot clench, and it allows for relaxing the lateral pterygoid to get the CR. What I would tell you that's most important, short-term use only. If you have somebody that has sore muscles, pop this in, get them under control, get records, and figure out what you have to do to their occlusion. You don't have to keep these in for the rest of their life. And the risk of something like this, because the back teeth are apart, is you worry about extrusion back here, right? You worry about back teeth erupting. Now, if you want to use an anterior deprogram more long-term, you can do something like this. And what this is with the B-splint is it's basically upper and lower retainers that cover the teeth that also have an anterior midpoint stop. So here again, you're still going to get the same reduced reduction, 80% of muscles. Again, only use for healthy TMJs. You can go longer term with it. But one of the things we just want to remember is there's probably not a need. If you can get the patient comfortable with this, you can probably move on and fix the dentition. But for whatever reason, the great thing about the B-splint, because it's like retainers and we're covering the back teeth, we don't have problems with posterior eruption, which we love. All right, so understand, and this is the key, any midpoint anterior contact splint, and this might be a question a little bit, but any midpoint anterior contact splint is best for muscle pain and contraindicated for joint pain. All right, so that's maybe the most important thing to remember there. All right, now let's look at the superior repositioning splint. And a superior repositioning splint can be on the top and bottom. It can be used on healthy joints, but most of the time we're going to be using full coverage splints on TMJ type patients. Why? Because when we cover the whole occlusion, we can idealize the occlusion. We can create, CR or adapted centric posture. We can create equal intensity stops. We can create anterior guidance that's nice and shallow. But with these type of appliances, what we're going to do is place them and then adjust them so that we always keep the occlusion ideal. Visualize with me if you have a patient with a joint problem and their joints are changing and breaking down and they're banging on interferences in the back, that increases muscle activity, which loads the joint. What these splints do is it allows us to, in plastic, to create an ideal occlusion that lowers muscle activity. The problem is, as the joint changes, the occlusion is going to change. And your job with these appliances is to just keep them adjusted, keep the occlusion ideal, and work along with the patient until the joints stabilize. And when they do, it's kind of magical. At that point in time, you can load test and you can take a CBCT and the joint looks better. And at that point, they're ready for phase 2. So I prefer, if this is a 24-hour-a-day type appliance, that I use a lower. This is more of a Tanner type appliance. Somebody asked about the Michigan splint earlier. Michigan splint has all the same goals. It's just an upper splint. So if I'm making more of a night guard and I want to idealize the occlusion, I kind of do a Michigan splint. But if I'm using, this is a long-term precision orthotic for TMD, I do a lower. Now, the last one that we'll talk about is a directive appliance. And what a directive splint does is it basically just creates a situation where the mandible is forced forward a little bit. I'm not going to get into this too much because it's basically an anterior repositioning appliance. We do it very rarely in traumatic situations when there's inflammation in the back of the joint. And we might do it for just 7 to 10 days with a bunch of steroids to get the inflammation down, and then we convert them back to a full coverage orthotic like the Tanner or the Michigan. So here again, when we start looking at our patients here, we're going to be thinking about doing our complete exam and doing our differential diagnosis. If you have an extracapsular issue and the issue is occlusal muscle type problems, they are resolved extremely well with midpoint anterior contact splints. Lucia-jig, NTI, or the B-splint works really, really well. Okay, so that's essentially what we're doing. We do our exam, we do our differential diagnosis. If it's occlusal muscle, then we're going to do a midpoint anterior stop type splint. When the joint starts to be involved and it's intracapsular, I would recommend, and again, even though it's may just be a lateral pole issue, you might be wrong in your diagnosis. So if there's anything going wrong with the joint, lateral pole, medial pole, or DJD, we strongly recommend that you go ahead and you do a full coverage orthotic, Tanner, lower full orthotic, or the maxillary one, which we'll show you in a second here. But that's pretty much it. This is equilibrated, again, to centric relation or adapted centric posture. You have equal intensity contacts, and you have guidance. Again, following us on Instagram or looking at the website is going to be important. Lenny Haas, who was with us earlier today, is going to be doing a free webinar, then a one-day class on splints. So we have a lot of interest in that, and he's really good talking about it. And then in our advanced track, Drew Cobb does a beautiful TMD class that's hands-on, that's all about handling these patients. And then the last possibility is if you do have the acute trauma and it's short-term, then using one of these anterior repositioning splints can be really beneficial to the patient as well. Key point here is adaptable joints are manageable, but not as stable as intact TMJs. And again, that's one of the things to really remember here. So what is adaptive centric posture? Well, it's the relationship of the mandible to the maxilla that is achieved when the disordered temporomandibular joints have adapted to a degree that they can comfortably accept firm loading when completely seated at the most superior position against the eminentia. So as we think about ACP, there's three possibilities. We have lateral pole displacements, complete disc displacements, and bone-to-bone type situations. So if we have any of these things going on, when we think about precision therapy, precision orthotic therapy, we are going to be using a full splint. And on a lower appliance, this is pretty much how it's adjusted. Again, equal intensity contacts. There's this is the lower splint, so those are the upper lingual cusps. There's your canines. There's the centric stops of the centrals, and then protrusion, it drags in this direction. So again, lines in front, dots in back, all over again. But we're going to basically keep this in until the pain is gone, until we achieve adapted centric posture where the splint's no longer changing. That means we're probably seeing them every week or two. We have comfort and stability. We confirm that the occlusion's not changing with our occlusal ribbon and with T-scan. And again, last thing I'd say is get a clean CVCT. I want to make sure that the scan is also clean. I like lowers for these TMJ patients because they can still see their upper teeth, and it's easier for them, I think, to wear 24/7. So how to adjust the orthotic? Again, check for comfort and placement. Make sure it goes in nice and passively. We ideally use contacts with the occlusal ribbon. You want to keep those lines in front, dots in back, and we're checking about every 2 weeks. So if we look at what this may look like, this is sort of weeks, this is July, August, September, and then again in November. Good idea to go ahead and take pictures as you're going along the way because it's going to change a little bit. But when you get to the point where it's no longer changing, that's when we have achieved adapted centric posture. That's when we start having comfort and joint structure is stable and the occlusion is stable. confirming with your ribbon, and if you do, have the T-scan. And once we have that point in time, then we can start moving towards doing our phase 2. Once successful occlusal therapy is achieved, proceed with 2D and 3D treatment planning, and new records will be needed to remount the case before proceeding. Remember that it's the doctor's role to find out if occlusal and TMJ problems are responsible for all the pain, some of the pain, or none of the pain, okay? And again, the great thing is those 6 things that we do plus the imaging that we sort of screen for is a great place to start. And then if you add in the layer of using an anterior bite plane to differentially diagnose the two, what I would suggest is if you have somebody with a displaced disc right now, let us help you find somebody that can treat that patient, because the precision of orthotic therapy can be a little bit more, there's a little bit more to that, and it will train you towards, but they can be frustrating if you're new to this. I can also say, though, if you are in a situation where the patient is just needing to wait a little bit, or you need to wait a little bit, making a full orthotic and practicing bilateral manipulation and creating an ideal occlusion in a plastic, where you get lines in front, dots in back, even if you're just making a night guard, is a great place to start. And that's why I say splint therapy, making night guards, and making deprogrammers, as well as adding the complete exam to where you are right now, is a great place to start. All right, a couple things here, and I want you to answer this question. So we're going to take this patient, and I'm going to tell you a little about him. So you've done a complete exam, and the exam reveals that you have a history of headaches, which are worse in the morning. They have nighttime parafunction. Patient can't open really wide. The temporalis and medial pterygoid muscles are sort of palpation. Firm loading with the TMJs relieved shows you tension and not tenderness, and there are no noises in the joint. Numerous teeth have wear facets on them, and maxillary cuspids are worn. There is a discrepancy between CR and MI. So just put in the chat box, would you be more likely to use a deprogrammer in this case, or a superior repositioning splint? Love it. Love it, love it, love it, love it. Great. So I'm seeing deprogrammers out the wazoo, and that's exactly right. So the first thing we would absolutely, muscle pain's involved, and they're clenching and parafunction, this is the absolute thing to do. So let's do another one. So now we do our exam, and this is what it reveals. You have a history of recent facial trauma. Patient can't open wide. The mild loading of the joints results in tenderness, and there's noise in both joints. Since the trauma, the bite has changed, and the front teeth do not touch to the bite. So there's the trauma was there, but let's not call it like this week. So it's been maybe a little while and enough time for these things going on. So there's pain and tenderness in the joint. There's some noises. The occlusion's changing. Are you going to use a anterior stop appliance, or are you going to use a superior repositioning splint? Pop it in there. Great. All right. Well, that's exactly right. Okay. So that really brings us into a good point to stop, and let's do a little Q&A here.
Okay, let me get the next poll question up. Alrighty, here we go. Which of the following are not part of evaluating the health of the TMJ? Screening history, imaging, anterior bite plane, looking at the vertical dimension of occlusion, or Doppler?
Pretty good runaway.
Yeah.
All right, so we can lock that one down, Joan.
Okay. That's right. Screening history, imaging, and anterior biplane and Doppler are all part of evaluating the health of the TMJ.
Yeah, and not changing vertical. Yeah.
Okay. Let's do
Which of the
next
following?
one.
Oh, sorry. Hasn't popped up. Yeah. If a patient has a clicking disc off the lateral pole, the patient can function normally.
Excellent. Doesn't seem to be much question about this. A little bit.
So the thing, and I want, there's a little nuance to this. So I'm going to give a little. I do look at this as true, but one of the things I just want you to remember is if you have that going on, and there's other signs of instability, and you maybe want to do a splint first, I'd still recommend you do the superior repositioning splint, just to verify that the joint is in fact lateral pole. You don't want to miss the fact that it could be a medial pole. But if it's truly a lateral pole disc displacement, and you can verify that, then you can absolutely equilibrate and do dentistry, and the patient will not have any symptoms. They can function normally. Great.
Okay, here's the next one.
If the patient has a disc in a closed lock off the medial pole, the patient is at risk for pain, dysfunction, and DJD.
True or false? That this is a runaway.
Mm-hmm. That's great. You guys have nailed that concept, which is important. And then the last one
is coming right up. Here it is.
Anti-deprogramming appliances are great for which of the following? Medial pole displacements, inflammation in the joint capsule, active DHJD, a tumor in the joint space, none of the above. Glad I asked this one.
Yeah. A few more people vote here. All right. Let's go ahead and share this.
Yes, let's be clear about this. So just remember that with anterior deprogrammers, midpoint anterior deprogrammers, they always load the joints. Now they'll decrease muscle activity, but they load the joints. So they are contraindicated with anything that you think is going on inside the capsule. So the answer is none of the above. You would not do it if you suspected medial point mole problems or inflammation, because it would actually make them hurt worse. And if there was active DJD, the loading would actually cause the condyle to break down worse. And I have no idea what a tumor would feel like in the joint, but I've seen a couple, and you wouldn't deprogram, you'd get them off to somebody that could fix that. All right, so what other, maybe a few questions, Joan, and I just want to make sure we don't cut into David's time.
Yeah, we had it down to 15 and it's back up to 65. So we're still typing, everybody.
Okay.
We'll do a few here. What if the patient's chin deviates to the left but has popping and tension in the right? Also, what does it tell if a night guard has made the patient's pain clenching worse in the past? Important one.
So one of the things I would say, if the clicking is over here and the pain and or the deviation is over on this side, there's two things to think about. It's possible that the problem is more chronic on this side. Just because you can't hear noise, they still could have degeneration going on. And sometimes the clicking and popping is newer. So they could have worse disease that's less noisy over here that's caused the shift. The other possibility that you have to think about is make sure they don't have something growing in that joint. I've seen an osteochondroma on the top of the condyle over here that's actually pushed the chin in that direction. So either way, if you've got that type of thing going on, get an image, get a CBCT and see what's going on. And then if a splint is making a person feel worse, then I would really take a look at the splint. Make sure that it's adjusted properly, that you are in adapted centric posture. Remember, it's not just a piece of plastic that's going between the teeth. And I see so many people coming in to me for second opinions that really have bad splints. And it's not, Pete wrote an article in the 90s called The Magic Appliance. and was basically saying that it wasn't the acrylic. It's not an acute deficiency of acrylic. It's being able to put something in there that idealizes the occlusion. That's what makes the difference.
Okay. Any opinion on using the Coits bow for the stratus articulator?
Yeah, so if you're using the Cois ear bow, it's basically doing the same thing as anything that provides you with the Bonwell point. And I think it's going to be accurate probably 90% of the time. So similarly with the digital, I'm totally fine using the little plate to give me the 100 millimeters, which is what the Cois ear bow does, or face bow does. But if I'm in a situation where I'm altering vertical, I want to be more accurate. And so that's when I'm going to use an ear bow, or digitally, I'm going to use the Bellis, because that will allow me to really be close to the arc of closure.
Okay. If you have a red patient with joint pain that is edentulous, how do you complete phase 1 of treatment, splint therapy?
So with an edentulous patient, about all you can do is make some sort of denture. And what we'll often do, and I've had patients like this, where I'll make the denture that will have basically a normal lower denture. The upper denture will have canine to canine, and then the back of the upper denture is just like acrylic. It's just a block of acrylic. And so it makes it easy to adjust. It's almost like putting a splint in there. Thankfully, I haven't seen very many TMD patients where they're edentulous.
Well, they don't have any interferences, that's for sure.
Yes, that's right.
How do I order an MRI correctly to get the right information about lateral pull, medial pull from the radiologist? Does the coil need to be parasagittal or oblique? Does this make a difference?
You know, the biggest thing that I would do, we've got a guy here locally that I would talk to them about who they've been listening to. The protocol that we follow is from a medical radiologist named Shellis, who worked a lot with Mark Piper. And again, I'm not an expert on getting the image. I just know what I want to see. And I want to see a T1 and T2 weighted image. And I want to know where the disc is on the medial and lateral pull. So I do know that our guy following Chellis uses some sort of coil technique. I don't know about oblique and sagittal and all that, but I know what I get. So I would just talk to them and see if they're following Chellis's protocol and go from there.
Let's do one more. I'm getting confused. Can you please explain what you do with patient with clicks? Does it mean that all clicking needs to be addressed with equilibration or splint?
Well, that's a great question. I don't think all clicks need to be fixed. And I'll maybe give I do view it as a sign of instability potentially, but the problem with clicks is the person could have fallen on their chin when they were a kid and loosened the lateral collateral ligament. So we don't always know if the click is a problem based on the occlusion. But what I do is that when I see a click, I'm always doing a very close evaluation. And here's the good news. When you see lateral pull clicks that are related to the occlusion, you also almost always find other signs of instability, like wear, mobility, migration, or sore muscles. So we end up treating it accordingly. But again, a lateral pull click may not go away. So if the patient is trying to make the click go away through equilibration, you just can't promise that. So I tend to, if a patient comes in and they've got a lateral pull click and there's no other signs of instability, then I tend to just observe that patient for a while. I don't necessarily jump in and treat them. And I think that's the appropriate thing to do.
Okay, I think we better take a quick break so we can get David started. Guys, we have now 76 open questions. We're going to keep typing answers. You have amazing questions, so we'll keep working on it. Let's take a quick break, and we'll be
then
back
I'll introduce David, and we'll keep rolling.
Rice.
Yeah.
Okay.
Yeah. Well, welcome back, everybody. I know we've thrown a lot at you today, and I want to spend the rest of the time having you listen to a really good friend of mine who is, I would say, a master at understanding some of the obstacles that stand in our way that may not always be clinical. And that's really what we want you to think about. And I said that yesterday. You need to be thinking about one side of your brain, about how you have to learn this content and understand the mastery system and develop these workflows into your practice. But on the other side of it, if you're going to be able to do dentistry that's beyond usual and customary, we have to communicate in a way and lead in a way that's beyond usual and customary. You can no longer just let, the whole thing, from the standpoint of just letting the patient, whatever the insurance is going to do, determine what it is they're going to do. In other words, we got to be able to build value. And so building value means that we have to talk differently, and maybe our practice has to be a little bit differently. But the cool thing is it's really fun, because anytime you're chasing excellence and seeing improvements, it's a really important part of what we do. And ultimately, I don't think that you're going to get a chance to do this kind of dentistry if you don't also evolve from a communication and leadership standpoint. David runs a organization called Ignite DDS that really has a tremendous outreach to young practitioners, dental students, and people practicing within the first 10 years. But I can tell you that the information is so good that old people might, like me, listen to it as well. And on the other part of this is we also have a podcast together with Pio Modi called Go To Dentist. And I got a funny Instagram last night about somebody who listened to us all day yesterday and then did 2 of our podcasts, and she wasn't sure whether she still wanted to listen to me tomorrow, but I hope she came back. It was maybe a little overwhelming. So with that, David, you're going to talk about case acceptance and leadership and management. And just again, thanks for being here, and welcome to Functional Occlusion.
Hey, thank you for having me, and thanks to all of you for bringing your time and energy to this. It's amazing. And so, John, I'm going to start with chasing excellence. Love the phrase, and perfect piggyback off the REM I Am Superman song. So couldn't be in a better spot. Gang, all of you here, this is, let's see how I'm going to make this go here. All right. This is fun dentistry, right? We're talking about functional occlusion. You guys are learning about functional smile design. I came in early and I listened to the last little bit, all about splint therapy, and you're talking about different issues with the TM joint and how to make choices. And this is what makes dentistry exciting and fun. And to John's point, it's the clinical side of our brain that's hard at work with everything you guys have done over the last day and a half. So first of all, congratulations to all of you for investing the time. The fact that you're investing in your patients, you're investing in your practices, and in my humble opinion, you guys are investing in your greatest asset. You is a really, really big deal. So don't underestimate the time that you're spending and have spent this last day and a half. It's going to bring you places in dentistry that most of your colleagues and peers won't get to who haven't made that kind of investment. So, as we kick off our time here today, just, I'm watching this chat box. I was watching it just go crazy, especially during that Q&A section. So I'll try my best to keep an eye on things. I know we've got a team of people, and Joan's here with everybody with Dawson. So I'm going to try to stay focused, but there'll be a few times I throw out just simple questions to make sure you're still with me here. And I want to start us off with just a couple simple things. So I would have to imagine, if you're here at Seminar 1, that a lot of this is somewhat new to you coming in. So are you feeling better today, right now, about your ability to treat some complex treatment compared to where you were before you came here? That's something you should be thinking about right now. And it's awesome, cool to see. Do you feel like you're in a better spot to treat your patients because you're pulling in all this new information? I mean, you guys are drinking through a fire hose right now. This is a lot of information. It's great information, but there's a ton there. So, and last question, if you hit me up here, because I love that we can have this feature, is anybody here want to learn how to tell their patients, say yes? I mean, who wants to have their patients say yes to all this treatment, because at the end of the day, I'm a huge believer on information that we implement being, it's our power. Otherwise, we're just really smart people who we learn to, yes, 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 loving it. So that's really cool. Let's talk about some things. So as John mentioned, you know, part of my life, about 60% of my life these days is with Ignite DDS, and it's everything that John mentioned it to be. We work a lot with young dentists, we work with young dental teams, and then we pass the baton off to our friends at the Dawson Academy on the clinical side and in other spaces to bring experts to you all the time. And then the other part of my life, I get to spend with these people you're seeing at the bottom of your screen. And I'm so incredibly fortunate, because I'll tell you, although our team has grown over the years, we've only ever lost 2 team members. And I think it's a tribute to the culture that we've built in our practice, a lot of which is based on what we're going to talk about today. And those 2 folks who moved on from our practice, they've actually moved into a space in dentistry that's beyond what I could ever give them in a private practice setting. So those were hard days because we lost 2 amazing people, but they were amazing days because part of our job was to help prepare our team to be, you know, the best people they could be, and give them an opportunity in life that, you know, maybe they wouldn't have had if they didn't learn all the things that we're going to chat about here today. So, you know, then there's this, right? So I'm guessing none of you, maybe none of you, were taught in dental school how to deal, how to manage, and I'll go so far as saying how to win at a time like we're experiencing right now, right? This is unprecedented. So our ability to have a plan in place to carry forward in our practices that helps us, you know, our trajectory continue to skyrocket is really, really important. And clinical is one massive piece. And what we're going to talk about is the other side of that coin. And for me, just like this moment right here and through right now, no one really ever taught me case acceptance at a high level. I learned some things. I learned some great clinical skill sets, but no one ever really gave me a way to quickly get to know my patients and build extreme relationships with them, and gave me something that was really predictable. So literally 9 out of 10 times I could walk into a treatment room and we could walk out and hear yes, not to the 1 tooth or 2 teeth, but to complete care, which is why all of you, I imagine, are here. So you can learn about complete care. So I just want to tell you a super quick story. You know, on my path to get here, young dentist, I did an associateship for a few years and bounced around because they didn't go as well as I'd hoped to. I didn't find a dentist who believed in all the principles that you've all learned this last day and a half, but I finally did. So I finally landed in a practice, and I'm an associate there for a few months just to kind of transition into it. And I remember this day like it was yesterday. I'm at the bank, and any of you who've purchased a practice know this, right? So I have stacks of papers, and I'm literally signing my life away, and hoping this whole thing goes really well, hoping all patients accept me as this dentist walking into a practice, and hoping they accept this higher level of clinical care that I've been working so hard on, even when I was an associate. And I remember I get back to the practice, which is now finally mine. I walk into my office for the very first time, and I look down at the desk, and on my desk is a stack of, no kidding, $27,000 worth of bills. They're mine. You know, for the first time, they're mine. And I still hadn't picked up a handpiece. So what we're going to talk about over the next, 90 minutes or so, and we've got a break in the Q&A to pause us here. We're going to talk about a lot of different things, but I want to talk about one main system, one system that took the practice that I purchased that did really well. So the dentist before me, good clinician, very good business person, collected around $600,000 a year. And in 6 months, a little less, but in 6 months, we'll call it, we doubled that practice. And since then, the people that you saw in the last picture, we've grown our team. So now we're not 1 dentist, we're 4. We're not 1.5 hygienists, we're 4. We've got 4 awesome dental assistants and 4 ladies who work on our administrative team. So we've grown and grown and grown. And lots of things, come into play for that. but we're going to talk about the really, really important things that make, you know, a massive, massive difference. Because I want you guys to have high impact. So when you get back to work and open your doors, if you have yet to do that, which I'm guessing many of you have not, you know, I want you guys to hit the ground running, because there's no time like the present. You know, if you go back and start implementing everything John has worked so hard with you on, you'll do it. And if you go back and you delay, if you wait a month, then at 4 weeks, 5 weeks out, I'm telling you guys from personal experience, it gets harder, because you're not going to be quite as confident as you are right now. So I want you to hit the ground running. So this is where it all begins. This image right here. There was a neuroscientist, his name is Antonio Damasio, and I'm not going to get into all of his research, but I want to talk to you about the science behind emotion and logic and how all of our brains work. It doesn't matter if you're left-brained or right-brained. This is how all of our brains operate. We're built this way as human beings. So he was an interesting scientist. A lot of experiments he did. He worked with patients who had neurologic deficits. And he did years and years of research on patients who, from trauma, had damaged limbic systems. So they had damaged emotional centers in their brain. And what he learned over the course of time is that those patients couldn't make choices, simple choices. He ran a long time experiment on eating a ham sandwich. And the patient could talk about how they liked white bread versus wheat bread, for example, or they liked ham with mustard versus mayonnaise. But when they came to the end of it and he said, okay, well, which sandwich do you want? Nobody could actually make the choice. So emotion is a very, very important part of our decision-making process. It's how you and I think. It's how our teams think. It's how our patients choose to do the dentistry or not, choose to say, hey, let's wait 6 months and a year. And then you guys know, right, if they're not in pain and it's not broken, and how long do they wait? Another, until something triggers them to make a different choice. So I want to talk to you about what we normally do, because normally we talk to that little guy on top, that rider. We talk about science, we talk about logic, we talk about rational dental things. I mean, we have a whole language that we use, right? We talk about mesial and distal and buccal and lingual. We talked all the last day and a half about the temporal mandibular joint and different poles of that joint where issues were. And sometimes we have that same conversation with our patients and it's over their head and they don't quite grasp what it is we're talking about. You know, we tell them we're gonna probe their teeth, right? 168 times with this sharp little poker, and then we're surprised when nobody wants to have this really ugly thing that sounds worse than the problem, quadrant scaling and root planing. And we wonder why people don't want to do all the dentistry that we want to do and we know they need. So the logic person is really, really important. So I don't want to underestimate the science behind the clinical dentistry. That's how we walk our talk. That's how we deliver complete care. How we have to speak to our patients and our teams as well is we have to talk to them emotionally. We have to get them here, because once we get them here and they understand and they know that we're on their side and they believe you're the right dentist and they're in the right practice, then we can connect the dots. Then we can connect the emotion to the logic and they'll understand that. That's the connection we have to make. But we've got to do something different than we've been taught before. We've got to talk to that big giant elephant instead of that little tiny rider that's on top. Because you guys both know, right? If that elephant wants to keep going to the right of the screen and that little rider tries to move him to the left of the screen, who's going to win? That big emotional elephant's going to win every single time. So all of these things are important. And in this group, all of us here today, this is a perfect example of why. There are many countries here. So we have people who are inside the United States, people outside the US. That brings a lot of different cultural difference. It brings different faiths, it brings different politics, it brings different race. Add to that things that your patients have in addition to that, wherever it is you practice. They have family dynamics, they have different levels of education. Some of them are military, some are civilian. They're different ages. There's different birth orders. There's a ton of science on birth order. And some of you who are in a family where there is a first, a middle, and a youngest child, you've probably lived whoever you are in that scheme your whole life. And like clockwork, you could define who was the eldest, who was the middle, who was the youngest. And we're going to focus today is on one really big one, and that's the one that in our practice helped us single-handedly make that first double. And honestly, probably helped us get to the triple. And when we got to the quadruple, it meant we were adding a bunch of psychology in addition to it. But this is DISC. So I want to talk kind of globally about DISC with you for a second. And first of all, understand that this is one of many systems out there. DISC is not the only system that you and I can use to assess a patient's behavioral style. There's Myers-Briggs, there's Fish, there's multiple systems out there. I like DISC in my practice, and I like DISC when I'm teaching you all and when I'm working with practices kind of offline, because it's a simple system, it's very teachable, it's repeatable, and then you guys know this, if for any of you who've been in business for any length of time, you can measure its success. You can measure it. And guys, if we can't measure it, then just like that elephant emotionally controls us, it might feel really good, but if it's not helping us succeed, if we're not closing 9 out of 10 cases up here with our patients, then it's information that doesn't really help us much in our practice and in our lives. So I'm going to kind of caveat our discussion with that as DISC. Some other things I want to talk about are, we're going to focus on your dental practice today. We're going to focus on your team and your patients and getting to yes. But this is a life story. So the skill sets that we're going to talk about today will help you have better relationships with your significant other. They'll help you have better relationships with your moms, dads, children, if you have them, cousins, friends. All of this stuff works because relationships are relationships are relationships. And where I want you to get within the 4 walls of your practice is that level of a relationship where your patients want to come to see you so much, where they trust you so much that they wouldn't think of going to a dental practice down the street who might be less expensive because maybe all of this stuff you're learning about is over the top and you don't need it, because that's what dentists who don't invest the time in all of this are going to say. They're going to say, it's like 2% of the world needs that. You're not 2%, you're 98%. But when you guys dive deep in this, when you get started, like John said, simple concepts and splint therapy, you're going to see how well your patients respond, both physically, how much better they feel, as well as how they respond to you as a dentist, because you've just taken your bar from here and you have blown it right through this computer screen. It's going to be incredible what happens for you. So let's talk about just some of the words that are here to describe the D, I, S, and C of DISC. And I want you just to kind of pay attention to where those words are positioned right now and some of the language that's there. And we're going to dive into this a little bit. I want you to pay attention to this too and understand this is a really, really important point. Another guy, W. Edwards Deming's super sharp economist, is the perfect example. We're not going to spend time on him today, but Google him later on. In the short story of everything that he proved over about 40 years in the business world, globally, not just US, so he was all over the world, is that a bad system is going to beat a good person every time. So that means all this awesome information that you guys are learning right now, if you have a system to implement it with your team on the clinical side as well as this side, then you're going to take your solid team member and turn them into a superstar. If you don't have a great system to deliver it to your team and to your patients, you're going to take a good or great person on your team and you're going to frustrate them. And I don't know about you guys, but the last thing I want is a frustrated team. When my team is happy, I'm super happy, super, super happy. So we're going to talk all about DISC. Couple more caveats for you. These are descriptors and we're going to go through each one of these, but a few more caveats for you. As we learn this today, if you're anything like me or anything like anyone on all of the teams I've taught, you're going to gravitate towards your style. You're going to look at your style. You're going to wish everybody on your team was your style. You're going to hope every patient that walks in the door is your style. And it would be nice if the world was that way, but we'll talk more about this in a few minutes. The world is broken down into percentages of each one of these styles. So whether we like it or not, there are chunks of people who are going to come into our practices who present as a high D or high dominance, as high I or high influence, high S, high C. So we have two choices. We can get really, really great at DISC, which I suggest. We can become a master of our lane, which I really suggest. Gallup has done a ton of research to show that we perform as teams, I think it's like 93% more successful when we stay in our lane of strength. So that's important. I also want to encourage you to, as you teach your team, to recognize, unlike I did in the beginning, that I didn't want everybody to be me. There was a strength in surrounding myself with people who had totally different strengths than myself. It made it a little more difficult at first because I wanted us to see the world through the same lens. But once we figured out as a team that we were better because I was a DI and someone else was an IS and someone else was an SC and someone was a straight C, collectively, we became a very, very strong team. And as we do this today, I'm gonna walk you through exactly how I learned this, 22 years ago, because philosophically, you're gonna learn it best that way and you're gonna implement best. So the first person you need to learn about is you. You have to learn today who you are. You have to learn which one or two of these kind of rise to the top when you're in your practice. You'll also learn that when you're outside your practice walls, some of you will have the same dominant feature. So some of you will be a D at work and you'll be a D at home. Some might be D at work and an I at home. Myself at work, I'm a combination. I'm a really high D. I'm also a very high I, and you can see the characteristics of both of those. But the moment I step out of my practice, the moment I switch off work mode with Ignite DDS, I'm no longer a high D and a high I. I become a high I and a high S, which is kind of unusual. So there's lots of nuances to this to understand that you are who you are at work. You may be somebody different outside your four walls, which is really important to remember because we practice in an area of high anxiety. So your team, if you don't have very high trust with them right now, and your patients, if you don't have very high trust with them right now, they may display themselves as one style. And as you get to know them, they may totally change their style because they just start breathing well, they just start relaxing, they start getting really comfortable. So they don't have to be this anxious person anymore. They can be the person they are home in your dental practice. And that's a really, really great place to get to. Let's see what else I want to remind you about. Strengths and weaknesses of each one. There's no right or wrong. There's just different. So we have to recognize it within our team, who's the second group of people, right? So you need to know you, number one. Number two, when you leave here today, and I'll help you with this. We'll talk about this later. I'll help you with this. But I want you to know who everybody on your team is. That's two. And then once you and your team know everything there is to know about each other, then you implement with your patients. And collectively, because you have each of these four styles represented, you can learn an awful lot about who your patients are. And it's literally, guys, I promise you this is going to be so cool. They're going to walk into your practice and it's going to be like they have this name tag right here. And it's going to say, hey, my name is David Rice, and I'm a high D and a high I. And then you're going to know exactly how to treat each patient based on their style, because you're going to have a system of questions when they call on the phone. You're going to have a way to treat them when they walk in the practice doors. You're going to speak to them a little differently in a consult room. You're going to educate them differently. All of these things are sort of going to come together for you, and one's going to build on the next and the next and the next and the next. But look at some of these descriptors for me. Look at who a D is. They're direct. They're very results oriented, firm, strong-willed, forceful. Now, some of you are going to look at these adjectives and you're going to think, well, some of those are great. And some of those things, maybe I don't know if I want to have those. but I don't want you to put yourself in a frame, or anyone you know and love in a frame, or any patient in a frame. I want you to just look at these as strengths and opportunities. And if there is a weakness in a descriptor, how are we going to overcome that weakness with our team? And how are we going to overcome that weakness with our patient? So now let's look at influence, right? We have outgoing, we have enthusiastic, we have optimistic, high-spirited, like super, super bubbly, right? We have in the S, in that stable category, very even-tempered people, very patient, very humble, very tactful. And last but certainly not least, on the conscientious, on that C, on that lower left, these are very analytical people. This is a lot of you that are here with us today. A little bit more reserved, precision is very important, a little more private, very systematic. That's why you're attracted to this education that you're getting in the first place. So, you know, I want you guys to really, truly understand that all of these have a time and a place. They're all really, really important. Nobody is better or worse than the other person. In fact, there's a really great book called Good to Great that Jim Collins wrote. He's written Built to Last, a few others well, but in Good to Great, Jim Collins talks about a really cool principle. And I want you guys to hang on to this for when we get to the Q&A later on, and hang on to it for when we wrap up today too, because I'll try to create an opportunity to kind of level this up for you guys when we're finished here today. But hiring team members, you know, Good to Great, what Jim Collins said is, okay, so the whole world talks about we have to get the right people on the bus, right? So dentists, office administrators, we want to hire the right people on our team. But where he gets to is we want to get the right people in the right seat. So we have to have the right player. We got to put them in the right spot. So as we talk about all of these as it pertains to your team, start getting your wheels turning as to why certain team members should display certain characteristics, and other team members would display others. So all of you who are asking about the slides, I will give you an email address at the end of this, and I will give you the slides. Is that fair? You guys get that in the chat? I'll make sure I give you an email address. I'll get you all these slides if you want them. So
that's great, David. Thanks.
You're very, very welcome. You're very, very welcome. All right, so let's talk about this. Now, I don't want you to look at these guys from a political stance, and I don't want you to look at this as a popularity contest. That's not what this is about. The reason I've selected these 4 individuals is because they're very identifiable. They're very recognizable. First, how I want you to look at them, and we're going to do this one a little bit backwards, but first how I want you to look at them is, do you recognize, based on those characteristics that I just showed you, and I will show you them again, anybody here who's on your team? Do you have a Donald Trump on your team? Do you have a Lady Gaga on your team? Now, Garth Brooks is a little bit of an enigma, so I'll tell you his story. You think of him as this really outgoing guy and really charismatic guy, and he is on stage. So remember we talked about how your disc profile can change depending on where you are? Well, Garth Brooks at work is a really high I. The moment he grabs his guitar, the moment he grabs his hat and he puts it on his head and he hits the stage, out comes the celebrity. Out comes this guy with all this energy. Out comes this guy who's very social, very interactive. Behind closed doors, Garth Brooks actually really quiet. He's this guy. He's the steady. He's the soft-spoken. He really just wants us all to get along. He's not that outgoing. In fact, I met him for the very first time in Nashville, Tennessee at the Ryman Theater. So one of the dental groups I belong to had an event where it brought in all these dentists who basically are part of a similar charity. We all gave back. So we all get invited to this concert. There were like 70 dentists maybe there at the most in the Ryman Theater, which is, I think it's the original theater down in Nashville, Tennessee, where all these country musicians kind of came up before the Grand Ole Opry and all the other stuff, the bigger theaters came around. So it's really old. So he's going to come and play for us. And a friend of mine who's a part of the organizer for this event literally had to go knock on his door for about 15 minutes to drag him out of his room to go on stage. And he's been doing this, guys, for 20 years. So this is his thing. So I put him in here a little bit because this is who he is on a personal note, but also to understand that we are different people in different circumstances. We are also different people as life moves on and changes, circumstances change. And we're very different people once we get comfortable and relax. But I want you to think about each of these people as a dental team member for you. Do you have them on your team? And then I want you to think of this, and this is going to be a little harder for some of you. Do you recognize yourself? Do you see yourself in the qualities that we showed before? And do you see yourself in one of these people? And I say that's more difficult because, you know, when we read those characteristics, you know, sometimes it's easy to get hung up on the negative stuff. It's crazy, right? We're dentists. We do this all the time. We go to our practice. We do, you know, 10 amazing procedures on 11 patients, and it's that 11th patient, that one tiny little thing goes wrong, and we go home and we beat ourselves up for it. So I don't want you to beat yourself up for any of the characteristics of the style you are. We're going to talk about how you can maximize your strengths with that style. We're going to talk about how you can help compensate for things that you aren't inherently skilled at. And then more importantly, we're going to build a team around you. We're going to build your ideal team around you in your practice. So when any one of these 4 people walks in the door, it's a piece of cake for you, because it should be that easy when you get that skilled. So think about these individuals on your team and these qualities again on your team. And let's think about strengths of each one of these. Talk about strength. So if you're looking at all of these styles here, and we're talking team focus, and you wanted, somebody just shout out in the chat group here, you wanted somebody on your team to do research. And maybe that research is on a new product, it's on a new technology, it's on a new bonding technique. Who's the best style for that? Yeah, C for sure. So yes, you guys are awesome. So now ask yourself this. Is that the person you're asking to do that homework in your practice right now? Because what would happen, just go across, go diagonally from the C to the I. What would happen if you asked a high I to do research? Picture it, because we've done it, right? We've made this mistake. Every mistake you guys can make, trust me, I've made it 1,000 times over. So picture the high I, and you say, you know, hey, Rockstar Dental Assistant, for example, we've got our Patterson reps coming in today, and I know they're going to bring us a new composite. And I want you to do the homework on that so we know if this is something we should really talk about or not talk about, and this person's a high I. Exactly. It won't get done. They'll be really excited about it. They'll be really enthused. They'll be super happy to see that rep coming in the door. They'll have a great conversation. They'll probably pull out their phones and exchange pictures of their families and all the fun stuff that went on, but nothing will get done. So that's just one scenario. Think of all the scenarios that are out there. Think about, who in this grid here, if you've done all your research, you've got all your facts lined up, because you and I are those people, right? We want to make sure we're precise. We want to make sure we're accurate. We want to make sure we're systematic. Let's say we've done all our homework, and now we need a decision to be made. Who do we call on? Because we got to call on somebody here. Yes, D. We have to call on that D for sure. We have to call on that D for sure. And again, so a lot of people look at a D and they think, oh God, the D is like the bad person in the practice. They're not at all the bad person in the practice. Now, I have to know my limitations in the dental practice. I become a high C in one area when I'm in the treatment room and I'm dialed in on all the clinical care that you guys have learned over the last day and a half, then my level of C, it rises. But outside of that, like, I'm not your guy to do all the homework. I'll do my research, but my partner, Mark, he loves the research, loves it. So the more research you give him, the more he can Google something, the more he can have, 55 textbooks, the happier Mark gets. Awesome. Now in the beginning, I'll tell you this. What I warned you about, I thought I'm a high D and a high I in the practice. Well, I couldn't believe Mark wasn't a high D and a high I. And I thought, well, this is the reason Mark never gets anything done. He spends 1,000 hours researching things, but he never makes a decision. He has this thing called analysis paralysis because he's so afraid to make the wrong decision that he never makes a decision. This is my brother-in-law too. My brother-in-law literally researched flat screen televisions until the flat screen TV that he picked out was obsolete and he had to start all over again. Now on the flip side, I need Mark II. That's you, I love it. But I need Mark II because if I make decisions like this and I don't do my homework, then that means probably I'm not always making the best decision. I could make better decisions. So I want you guys to think of each of these positions in your practice and find the win. Let's say I'm a high D dentist. I'm a high D dentist. Which style best complements me in a treatment room when I'm working with the patient? Who do I need most out of all of those styles? Yeah, exactly. S's are pouring in like crazy. I love the person who mentioned high D, because when I learned this, that's what I wanted in my room, right? I wanted somebody who was going to work with me and we were going to move and we were going to group. But I want you to think about what happens if I have a patient in my chair who needs their hand held a little bit. And my instinct, without knowing what we know here today, because now I can change, I know better. But my instinct is to get in and be like, let's get this done. I need my assistant to be a high S. I need my assistant to carry that ball for me. I need him or her to hold the patient's hand. I need Holly to kick me under the chair and say, David, Marty needs more time. You know, and obviously she doesn't tell me out loud. I have a really bruised right leg from all the kicks over the years. But think about all the opportunities. So in the beginning, when I wanted everybody to be just like me, man, I was totally off base. I wanted to build a team. You guys want to build a team of people who are really diverse. Not just in this, obviously, diverse in all those things I showed you on that one page, but really diverse with discs so you cover every single style. And then when you guys sit down in your huddles in the morning, man, think of that. We don't talk about clinical dentistry in our huddles. That's stuff we talk about the night before. But in our huddles, as a team, when we talk about, we grab a piece of paper and we have our checklist. We're like, okay, David Rice is coming in. Who is he? He's a high D, he's a high I. Okay, how are we going to treat him differently than the high S or the high C? And that's what we're going to talk about when we start diving into patients, which is going to be really cool because you guys are going to watch patients flip a switch. You're going to see patients that you have treated for a year, 2 years, for 10 years that you couldn't connect with. And they're literally going to flip a switch and start saying yes 9 out of 10 times. There's never going to be 100% in life. I wish I could promise you that, but 9 out of 10 times it's going to work. Okay, this is important, and we're focusing a lot on team right now because I truly, this is going to shock some of you, whether you know me or you don't know me, but I am not a patient-centered dentist. We are not a patient-centered dental practice. Now, we love our patients. We take great care of our patients. We give them 5-star clinical care. We give them 5-star, what do I want to say? Service. We give them 5-star service. But I'm a believer in being a team-centered dentist. Team-centered. You guys know this, right? You've all let's pretend it's pre-COVID. Let's pretend it's Tuesday night. You've had a great day at work. You're going to meet up with some friends, or you're going to meet up with some family after the day. You're going to go to their house and you knock on the door, you ring the bell and you say, hey, my God, we're here. We're going to have a great dinner. It's going to be amazing. And somebody in the relationship opens the door and you see their body language and the look on their facial expression, and you realize that some kind of crazy discussion happened before you got there. We've all experienced that. So do you think the same thing happens in your practice? Do you think when your patients walk in the door, they feel the vibe? Remember that emotional elephant? They feel the vibe. That's where it is. And when they feel that the vibe is off, then that little rider never gets engaged, because the only thing your patient is thinking is, how do I get out of here? How do I get out? And when you say, hey, does that make sense? Are you ready to move forward? They say yes. And then what happens? They don't show up. Why? Because they literally turned you off. So I want to talk to you really quickly here. This is what most dental practices do, and the first mistake we make as it pertains to human behavior. When we hire people and we train people, because I get this call, I don't know, 20 times a week. David, I need a new great front desk person. I need a new great hygienist. I need a great dental assistant. I'm like, okay, but what are they going to do? What are they going to do? Who do they need to be? Because if I'm a really high D, we talked about this, right? If I'm a super high D and I need a dental assistant, I probably need someone who's an S style. So it makes sense to hire someone who's really passionate. It makes sense to hire somebody who's really enthusiastic and wants to learn. It makes really a lot of sense for me to hire someone who's going to be supportive. So that's a very different hire. Can a dentist be a high I? Love that question. Yes. So I'm a high D and a high I in my practice. That is both a strength and a weakness for me, as each of these styles are. So I'm glad you brought that up. Let's just jump into it. So let's picture this. You're really enthusiastic when you walk into the practice. Call you Gaga. I love it. All right. So all you high eyes will probably just be like littering this thing, right? Because you've been dying right now. You're locked in your house. What the heck are you doing? You got to have a party somewhere. Let's have it here. So imagine, again, because I have a lot of I in me, and I'm walking into a treatment room, and this is a true story. I walked into a treatment room. It was literally the week after we really started learning this, and my patient was a high C. And I'd been walking in that treatment room for probably two and a half years with this particular patient. And every time I walked, I'm like, hey, great to see you. Happy Monday. How was your weekend? What's going on? And I think that my patient is loving that I'm so excited and enthusiastic. But if anybody's a C here and willing to share, what would you think of your dentist, the person who's supposed to be really professional, right? I should have my coat on, my hair should be perfectly combed, I should be very professional, I should be very accurate. And what do you think they thought? They thought I was, a lot of energy would be really nice. This patient probably thought I was crazy. You'd feel like I wasn't serious. I love that. You feel like I was crazy. Oh man, you guys are awesome. Yes, 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 yes. So the day after I'd really like digested all this information and our team really digested it, think I was phony. I love that. I walked in because I knew this patient was a really high C. She was very, very analytical. And we talked about her in our team huddle because I don't want to treat her in a way that makes her feel uncomfortable. I want her to feel good about coming into the dental practice. So I'm not talking to you guys about like some crazy voodoo magic and pulling the wool over people's eyes. What I'm talking to you about is I genuinely want her to feel good. I genuinely want her to like coming to our practice and to believe in our dentistry because we work so hard with our clinical education. I know our level of care is beyond anyone who's around us. So that day I went in different. That day I went in and I went in very serious. And I had a very serious conversation. I was very task driven. I was totally dialed in and I was very, very focused. And the coolest thing happened, and I kid you not, this is exactly what happened. She turned around and looked at me, and all my patients call me by my first name, by the way. She said, David, I have to tell you, that was the best hygiene appointment I've ever had. Now, remind you, I'm walking in for like the exam at the end, right? So she spends all her time with Shannon. She's seen Shannon since she's come in. She still sees Shannon 20 years later. And I looked at her, I'm like, may I ask why? And she said, because for the first time you walked in and you were just calm and super level. And that made me feel better. And then I did what I hope all of you do. I literally said, thank you so much. We just invested a ton of time as a team to go learn more about you so we could treat you better, not just with the clinical side, but with all the other stuff. So thank you for noticing, right? This is not a bad thing. This is an amazing thing, guys. This is such an amazing thing. And I can tell you like patient after patient after patient, people that we walk through and we have those experiences. But, you know, I had to fail, right? I had to fail a bunch of times to learn the lesson. And I'm not sure how long all of you have been practicing, but I'm going to hazard a guess. you at least went through dental school and you have a little bit of time under your belt, but you've probably met patients and you either thought it went really well and they never said yes, or patients that you just kind of butted heads with. Guys, you butted heads just because of this, because inherently a D likes a D in the room, a C likes a C, an I likes an I, and an S likes an S. And your team members are exactly the same. I learned that lesson the hard way. My partner, Mark, I told you was a really high C. She still works with us. She's awesome. Kelly on our team is one of the most brilliant dental assistants I've ever met. And she is the highest I I've ever met. So imagine how much they clashed, just like I did with that patient. And Kelly came to work every day trying to please Mark enthusiastically. And Mark came to work every day, or maybe left work every day going, oh, good God, Kelly, would you just please focus on the teeth? And when we learned all of these things, we could look at each other and be like, oh my God, thank goodness we learned it. We can actually have some really great conversations with people now. And when Mark needed energy in the room, oh man, Kelly was the best. And when Kelly needed serious in the room and level-headed and calm, Mark was the best. Really great stuff. So think about that. These two are opposites, which means when we're hiring a team, when we're building a team, when we're training our team, there's a distinct advantage to pairing D's and S's together once everybody sees the benefit of it, right? Don't just throw people in. If you guys could, please don't go back and throw the D's and the S's in together. Don't go back and throw the I's and the C's in together because they'll kill each other. But once you have this conversation, you have this great team meeting, start talking about all this stuff, pair people together, maybe who've always been a little distant with one another. And what you're going to find is that yes comes even easier, because as great as you're going to be with DISC when you leave this program, you are going to be a rock star when your team is on board. Here's why it's crazy important, guys. This is super important. Remember I told you, statistically, there are percentages in our population. So I want you to imagine this. If you're a high D, if you're a driver, and you think that you're doing the right things and saying the right things to your patients and your team every day, 3% of the time you're correct. 97% of the time, somebody's taking you the wrong way. And I give a really fun course. It's called 7 Seconds. It's all about first impressions. But imagine that. Imagine you're making a first impression every time someone calls on the phone, they see your website, they walk in the door, they sit in a treatment room, they sit in a consult room, and 3% of the time, right? I'm going to read this question. How is Dr. C with Assistant C working out? So Dr. C in our practice still works with Assistant I, because we fixed our perspective on things. Now, Dr. C and Assistant C, that's a killer clinical combination, right? But if you have a high energy person as a patient, how's that working out? Because it works both ways. It works both ways. But now look at this. So I's, you're a little better, right? If you're high I, 11% of the world, that's not bad. That's not horrible. And then let's look at S's, right? If you're a high S, congratulations. Almost 70% of the people in the world are you. So your default personality, your default style probably makes it so you get along with an awful lot of people. Awesome. And C's, 17%. 17%. Now, I'm going to tell you guys this with a little caveat here. And the caveat is this: birds of a feather flock together. It's why, whoever took care of you as a little kid, mom, dad, aunt, uncle, grandparents, whomever raised you as a kid, didn't want you to play with the bad kid down the street. Because if you hung out with the bad kid, you'd probably become like them. So what I see as I run around the country and I work with all these dental practices is people who don't have this skill set, they develop a team of a very similar style, and they attract patients of a very similar style. So if you're an S and you attract 70% of your community, that's not bad. But what if you're a C, who a lot of us in dentistry are? It means you're missing out on a major chunk, an I and a D, and worse and worse and worse. So that's my team. We're going to talk a little bit about natural laws when we come back here, but I think we're pretty ready for Q&A. I'm going to suffice natural laws to show you this. I like them. That's my partner, Mark, because they hold true every time. So Mark is displaying the natural law of gravity, which in essence means on planet Earth, he's going to get pulled down every single time, no change. We talked about the first natural law, emotion, looks like that. There's another natural law, and again, we'll dive deeper into this later. I can tell you more about after our program too, but the law of the herd is another really cool law, and I want you to think restaurants here, and think about this, right? Remember when you were a little kid, and mom or dad told you, if all your friends jumped off a bridge, would you jump off a bridge? That's the law of the herd, and we see this all the time. When everybody who already owns an $800 phone lines up for the next $800 phone. We see it with these spinners. Like, who buys those things? You know, guys, in the first 6 months these silly things came out, they sold $19 million of them. So people do what they perceive everybody else is doing. So we can use that natural law to help our patients understand dental treatment. We can use that natural law when we're trying to guide a patient to a specific place in our practice on a schedule, for instance, right? So you guys are learning that with really complex care, we're going to bring people back. We're going to take we have a records appointment. So we want to be able to guide them. It's a really great one. And last one is this, and I'll talk about 30 seconds or less. Natural law of integrity is people want to be the people they promised you to be. They want you to be those people. So think of your favorite restaurant. This is one of my favorite restaurants in St. Pete, Florida. It's called Brick and Mortar. And like clockwork, what happens at Brick and Mortar, they're a little old school, but this can happen both digitally as well as live. But when I call and I make a reservation at Brick and Mortar, because it's this tiny little place, the last thing they say to me on the phone are the same things that we can say in our practice all the time so our patients show up. Will you be here? Last 4 words. Will you be here? It's how you gain commitment. So we're going to talk about gaining commitment from your team. We're going to talk about gaining commitment from your dental patients. We don't want to go through all this clinical stuff you guys are learning today and then find out that people aren't going to show up for it. So I know it's our time for questions. I am happy to entertain them. I'm not sure how this is going to work with us now. Let me see.
Okay, David, I can read you some.
Awesome.
From the question box.
Sure.
One question was, how about the office manager? Meaning, I think, what kind of behavioral style would you look for them?
I love that. So, and I know I breezed through that pretty quickly. How I want you all to start thinking is, don't hire a position. Hire for all the qualities that you need in that position. So if your office manager is going to be somebody who is dealing with your team, as well as making some hard decisions, then maybe that DI style is going to be helpful. Now, if your office manager is going to be looking over books and dealing with numbers, then they better have some C quality to them. So for any position in your practice, I want you all to think about what are all the skill sets that they need to have, and then hire a style based on the skill sets.
Okay. Can the dynamics of a practice be off if the dentist is a high CS and the assistant is more dominant?
If you haven't studied this, great question. Absolutely, because then somebody, it's that bad apple on the team that everybody looks at and says he or she gets whatever they want, and then we're in trouble. However, when you study all of these things and each person on the team understands what their strengths as well as their weaknesses are, then you can teach that high D team member when it's really great, when you need their help with that D in decision making and keeping you on track, right? That's a great person to keep me on track, because if I was a high I and I talked too much, then Holly would need to kick me for not staying on time all day. So it's about maximizing strengths and everybody in your team being really highly engaged with this.
Yeah, let me chime in on that, because I think that's a great point. I do think it can be extremely detrimental if you're not exposed or trained on some of this. And for instance, I'm a high D and I have a kind of a C hook, which is again kind of weird, but I've kind of aligned myself with my assistant. My main assistant's kind of, she can be a high I, but she has a lot of S in her too. And so we have to really understand each other. Like I can hurt her feelings really easily.
Yeah.
But so I can't necessarily speak with her as directly as I can with my ops manager, who's also a D. We can say anything to each other, but from the standpoint of us working together with patients, she totally is thinking about all the touchy-feely stuff when I'm totally clinical, and I need that. I mean, it's just not what I go to. I have to work to think that, and sometimes it drives me crazy because it's taking time, but it's the best for the patient. Yeah.
Great point.
How can you determine which patient is who?
Love it. We're going to talk all about that in this next segment here. For our practice, what I'd recommend for all of you is you're going to pre-screen your patients. Just like you're pre-screening people for COVID when they come back, you're going to pre-screen them before they come in. The more you know about a patient before they ever walk in the door, the better. So we'll kick off the afternoon with that.
Okay. He says, what are some of the things that said and did that helped you to quadruple your first year revenue? More specifically, how do you get 9 out of 10 if finances are always an issue since dentistry is expensive?
Love that question. So, and John, chime in too with your experience. First, I'm going to say this is a great first step because this is easy. If you've never done this before, this is an easy win to get you to that first major step. And then we're going to integrate some of those systems that I alluded to on that one page where we talked about how we study age and generations. We study gender, how men and women behave differently. We study culture. So if I have a patient who comes to our office from Spain, that's a very different person than somebody who comes down the block. So all of these come together, and at the end of the day, it's work as well as increasing your clinical skill sets. So you walk your talk, because at some point you're going to build this brand that people feel really good when they come to see you about who they are, and they got outstanding dentistry that nobody else in the community can give. So those two things help. And then the last part I would share, and we'll touch on this afternoon as well, is most of us are taught that money is the largest obstacle. It's been my experience that just isn't always true. It happens, and we can help those patients, but it's often something other than money.
Yeah, I agree with that. And I do think, the reason we're kind of putting this here is we tend to attract dentists who love dentistry and love the clinical side. And what I want you to be exposed to is it's, we kind of have the belief that if we have the best margins, the most beautiful restorations, that, that's all we need to do. But it's a people business. And the more that you get your team understanding the things that David's talking about here, that means that the screening for, it's crazy, but not only the disc stuff, but my front desk people can talk to people and almost assess the green, yellow, red stuff that we're talking about in terms of occlusal disease. I mean, they know a lot about these people from just a conversation, and start thinking about where they're going to go. And, maybe if we need a little more time, if it's a really high I, who's going to be the one that does the clinical interview? And so what we're talking about is high-end dentistry. When we start getting people to do bigger cases or bigger things, part of your brand has to be that they feel a relationship with you. And part of the fastest way for them to feel a relationship with you is if they trust you. And if they trust you, they'll trust you quickly if they feel like they're being listened to and communicated to in a way that they understand. And so if you start communicating from your style to everybody, that means you're going to be right only when you're talking to your personality type. And so So again, the disc is a great thing to study. But the other thing that I want you to think about is when you start to have staff meetings and talk about the direction you're taking to the practice. And if you study with us and you start doing advanced records and train for that, train for this too. Train for this too. I mean, you have to train for the behavioral side, and it's got to come from you that this is important. And it does seem a little awkward at first if that's not necessarily your makeup, but it's hugely important. And the last comment I'll make, and I'll totally agree with David on this, is that I do think a lot of dentists just show up thinking that what we do is expensive and no one is going to accept it. And you just can't think like that. I mean, you have to think about, Dr. Dawson finally broke through with me, convincing me that it was my responsibility to tell everybody what's going on in their mouth and what was possible for them. And if you're worried about that, then just say that. You know, I'd even say it's a little uncomfortable for me because sometimes dentists can be expensive, but it's really my responsibility to tell you about the things that are going on and what's possible. And what you do with the information is up to you. But that's our belief here, and that's what we do. And you'll see people sort of relax because they realize you're not shoving something down their throat. It's just information. But a lot of people, you'll be shocked. Then what happens is people start saying yes, and then you have to figure out how to really do
it. Last one, what behavioral style would you suggest for an IS doctor? That must be about an assistant.
So if I had an IS as my style, I'd look to the other side of that graph. I would know as a high I that I probably tend to do this, talk a lot. I know as an S, I probably try to be making all my patients super happy. So if I had another I in that, are we still here, guys?
Yeah. They just stopped sharing your thing. So
okay, awesome. If I know also that S tries to make everybody happy, so the pleaser. So if you have a high I and a highest in your chair, you're going to have a great time, but you'll never do any dentistry. So I want somebody who's analytical in my corner. Having decision around isn't a bad style either. So always think of that old adage of opposites attract.
Right.
There's a good reason for that.
Mm-hmm. Yeah, okay. Absolutely.
All right.
Should we give them maybe
John, let us know when we should do the break.
Yeah. Why don't we do like just a 3-minute quick stretch, and then we have about another go till like 4:35, something like that. Is that perfect for you, David?
Oh, that's great. Yep, no problem.
Okay.
I'll get it done.
All right.
Great.
All
Quick break.
Right. Couple of minutes.
Okay. So let's continue on then.
Okay, awesome. So listen, I'm going to teach you guys a skill set to help your team members be more willing to help you, and as well as your patients and family and friends. And here it is. All you need to utter are these words: I need your help. Four words. I need your help. So I need your help because on this slide here, it's kind of cool. Friday, if you're totally bored, bring all your digital rotten vegetables because I'm guesting on the doctors, and I went to bat for us dentists. So I'm probably not going to be the popular guy in the show, but I just want to let you know that I stood for what was right. So any love is appreciated. All right, let's talk about this. A lot of what we talked about in part one of this is perspective. We all see life through our own lens. So those of you who've seen me speak before, I've used this image multiple times, but it's a powerful image and an easy image to look at. And there's 600 and some of you who are hanging out right now. And if we were in a real room together, I would venture to guess that about half of you would have looked at this image and inherently seen the young woman first. And the other half of you would have looked at this image and seen the older woman first. Yeah, and that's how this always breaks down. So I want you to give that pause for a second. We collectively have a lot in common, We're dentists, we are kind of science geeks, We go to work too many hours a week to do the same thing to help patients, get great smiles, feel better, all this wonderful stuff. I love it. Keep chiming in, gang. It's kind of fun. The ears, yeah. All right, I'm gonna let you guys help each other out on that one while I chit chat. Imagine that you inherently saw the young woman and I'm your patient, and I inherently see the old woman, and you can't figure out why I'm not getting it. A lot of this is DISC. The goal of what we're talking about this afternoon is to help you see what your patient sees. I'm going to repeat that. The goal is not for you to hit your patient over the head and say, hey, I see the young woman, you see the old woman, you're wrong. Because clearly we're both correct. No matter who we see, we're all right. So the goal is for you to really understand whomever it is on the other side of the screen, who's on the other side of a table in a chair, because once that patient really knows that you understand them, that you've listened, that you understand, that you care, you're here to help them first, then everything you learned on the clinical side, it just starts flowing. And John brought up a really, really great point. I loved it. What you may not have noticed that he did is he, in essence, he asked his patient for permission. He asked his patient for permission to share this uncomfortable, awkward thing that maybe is overwhelming for some people. We do that all the time. So as you guys are thinking about, how do I get all of my patients to do comprehensive care? How do I get this complete care thing going? How, if it's 10, 20, 30, 40, $50,000, when I believe that that's a lot of money, do I help them to understand how important it is? And that how is to start off, as you get to know them and you build this relationship and who they are, is to simply ask for their help and ask for their permission. I do it all the time. Mr. or Mrs. Smith, we've got a lot of information to go over, and you know what? I'm a dentist. So all of this makes perfect sense to me, but I get why it might not make any sense to you. So, do I have your permission just to share everything that I see? I want to get a yes. And I think most, not everybody again, right? 9 out of 10 people will say, yes, that's why I'm here. Excellent. Mr. and Mrs. Smith, I also want to give you permission. If there's anything you don't understand or you have any question, would you please feel comfortable just shouting it out to me? People are going to say yes. And then the last part of this permission is, I want you to know, Mr. and Mrs. Smith, that you can accept all of it, some of it, or none of it. And that doesn't make you a bad person. This is about your health. I'm here to be your advocate. I'm here to help you the best way that I can. But as Dr. Dawson taught us all, it's my responsibility to share with you everything that I see. Does that make sense? And 9 out of 10 patients are going to say, oh my God, of course it makes sense. And there will always be that 1 out of 10. And I want you guys to, if you forget all the amazing things you learned here today, I want you to remember this. Don't build your business around 1 out of 10. Don't build it out of 1 out of 10 team members. Remove the team member. Don't build it on 1 out of 10 patients. Remove the patient. Focus on the 9 people that you can help, who want your help. It's the best way to practice every single day. Here's what we're trying to avoid. I have a husky, so I had to show you a husky picture here. But we're trying to avoid this, backing yourself into a corner. That's a really, really bad space to be. You guys know this, right? Because I bet you if you've ever said the wrong thing to somebody and thought, oh my gosh, I can't believe that came out that way. Or that's not what I meant at all. But you know they heard it the wrong way, even though you tried to share the right thing. Your blood pressure goes up, you start getting all hot and bothered. And then what happens? You lose your place. You can't find the words anymore. So as we go through just in detail this afternoon on things to do with your patients, so you get to that 9 out of 10 benchmark, it's about not backing yourself into a corner. It's about talking less and listening more and giving your patients the opportunity to tell you their story. And the more rapport you build, the greater the relationship you build, the more they're going to share their story with you. So quick recap, quick refresher. Let's shift gears. We're gonna pretend that these are for patients now. And would you recognize those patients if they walked in your front door? Would you recognize Donald Trump? So imagine you have this patient, male or female, and they have an 8:30 appointment. What time does Donald Trump show up? At like 8:15, right? And he's up front and he's doing this. To whomever gets the blessing of seeing him in the morning, he's tapping his watch, he's tapping his feet, because even though his appointment's not for 15 minutes, he has an expectation. He's a results guy. Time is important to him. So he wants to get it done. But I'm guessing you all would recognize who he is. Versus Lady Gaga, and there were a lot of high eyes in our chat here, so feel free to jump in at any point. But Lady Gaga's out there. Would you recognize him or her when they walked in your practice? Because they might be on their phone, but they're definitely excitable. They're going to be really happy to see you and your team. And this is where, like, the party gets started. And then I want you to think about Garth Brooks. And I want you to think about how this soft-spoken person enters your practice. I want you to think about the benefits of that. I want you to think about the risks of that. And me and Bia look the same way. And we are going to talk. I like coming in. Hey, that's awesome. Yeah, that's how Gaga's walking in. But each of these styles is a patient that I know you all can recognize. And we're going to kind of dig deep into what that means. And we're going to start with this because somebody brought up money as our part of our Q&A. So that was a perfect lead-in. I would guess that most of you have been in an Uber, maybe it was a Lyft, but you've been in a ride share, and probably a fair number of you have also been in a taxi, in a yellow cab, in some city somewhere. And you choose to take one over the other for some reasons. And it's going to be a little different to do virtually, so I'm just going to kind of talk at you a little bit. I apologize for that. But some of you choose to take an Uber because it costs less, unless you're on peak time, right? Uber's pretty financially easy on you unless you're at a peak time in a big city, and then it gets a little painful. But some of you do it because you walk in an Uber and it's clean, it's neat, it looks nice. Some of you do it because it's easy and timely, right? You've got this cool little app, whether it's Uber or Lyft, and you just program in, hey, come pick me up, and you can schedule it. Man, that's really time is issue. Some of you trust an Uber more, because what happens, instead of a stranger pulling up in a random cab, somebody rolls down the window in most places today and says, hey, are you David? Yeah, I'm David. Uh-oh, I'm Sarah. Hey, Sarah, nice to meet you. So there's a little more trust because we know who each other are. Sometimes it's about comfort because it is a little nicer car, and sometimes it's about wellness, it's about health. And I want you guys to ask yourself, if that's how you think, and emotionally you choose one of those two to get from point A to point B, and then you logically rationalize it, right? For money, appearance, time, trust, comfort, health, one of those six. Do you think your patients make the same choices? Money, appearance, time, trust, comfort, and health. So somebody brought up money. Yes, for some of your patients, money is how they make decisions. That's how they choose. Some of you make your choices. Some of you chose Uber because it was less expensive. But I want you to remember that there are 6 drivers, guys, and money is one of them. So how we're using DISC is we're getting to know somebody at a really deep level, and we're doing it quickly because you guys know we don't have 10 years to figure out who David Rice is anymore. David Rice already moved to 3 cities in 10 years, or a different dentist down the street because he got frustrated, or he stopped coming to the dentist because life got busy. But if David Rice is a money decision maker, then DISC will not only be helpful to build our relationship, it will help you understand that money is important to me. But it might not be money. Money might not be important to me at all. All of you, yeah, from patient perspective, perfectly said. So trust, some of you are chiming in, that's awesome. And chime in if one of these, if you identify with one of these, it doesn't have to be about dentistry, about whatever you buy. But some of you have patience, and for some of you, it's this. It's not how much money the smile costs. It's, can you make me look great? Are you the dentist who can put in 10 restorations, equilibrate me, get my jaw happy, but make me look great? Because appearance is really important to me. For some of our patients, it's gonna be time. Think about disc styles. Think about Donald Trump. Time for a D style is really important. That's why they're fact driven. That's why they show up 15 minutes early for an appointment, because they want you to be ready on their clock, right? That's what helps. So money, appearance, time so far. Let's talk about this, trust. This is a big one. This is a big one inherently of the 6 for a lot of your patients. This is also really where we're trying to get all of our patients. We want to get high trust. That's our goal. But some of your patients, they don't care how much it costs. They don't even care how pretty it looks. They want to know that they're in the best dental practice in your town. They want to know that when they sit in your chair, whatever kind of dentistry they need, it's the best dentistry they can get, and nothing else matters. You guys have all met those people, right? Next one's comfort. You're going to have patients, they don't care about money, appearance, time, or trust. They just don't ever want to be in pain. Doc, if you're going to restore a tooth or multiple teeth or all my teeth, or you're going to treat me periodontally or all of the above, then I need to know that I'm not going to go home and be dying. Now, you guys know that sometimes patients get uncomfortable, right, post-operatively. So we always want to be the hero, right? We always want to share with our patient before we do treatment what all the risks are. We always want to emphasize, what could happen. So when it doesn't happen, our patients say, oh my God, you told me it might hurt for, 24 hours. And I went home after that extraction and I felt like $1 million right away. So yes, people can tell if you're honest or greedy. Absolutely, people know. People know. So we're trying to identify what matters most to a patient. Because I'm here to tell you guys, it doesn't matter what matters most to you and I, they don't care. A patient, think of every patient who walks in your door with the letters WIFM, with them. What's in it for me? That's what your patients want to know. So you and I understanding what matters most to them is very, very helpful when we're trying to teach them that all of these things you're learning about for the last day and a half are important, that we're trying to teach them that we can avoid like all this pain and suffering down the line by getting in there and treating you now. Because a lot of the stuff doesn't hurt, right? So we have to overcome the fact that it doesn't hurt me today. And this is the last one, health. Money, appearance, time, trust, comfort, health. Some of your patients just want to know that whatever it is you do, it's going to make them the healthiest person they can be. And I chose this specific picture because this is a really good example of crossover of disc and another skill set that I alluded to earlier, generations in age. So people who are baby boomers, they care an awful lot about their health. I know this is an ad, but look at they captured the expression perfectly. Look at how they're looking at that grandchild. They want to see their grandchild grow up. They want to watch their grandchild graduate from grammar school, high school, go to prom, go to college, get married. So you and I understanding this, the emotional elephant behind why our patients make their decisions, it's really important. So let's go back to this real fast and add a layer, because as we look at DISC, I like to divide it in halves. So somebody asked a question of, well, how do you start identifying these people? Which is what we're going to talk about. How do you start identifying them? Well, on the phone, we start asking them questions that you would normally ask people, but we're asking with a little bit different slant. I want to find out if whoever's on that phone lives on the left side, are they a D or a C? Are they task-driven people? Or are they an I or an S? Are they people-driven people? So I'll give you one example. Simple question, somebody on your team is probably already asking, but we ask it with intention. And when we ask it with intention, we get an answer that helps us narrow who this person is. So you guys are probably asking it, but hey, Mr. or Mrs. Smith, how'd you get here, right? How'd you get here? And they're going to come from multiple sources, right? So they could come from the internet. Maybe they Googled you. Maybe you had tremendous Google reviews. So you want remember the law of the herd. People do what they perceive everybody else is doing. Think of Google reviews. That's why we do them. That's the why behind Google reviews. You guys know if you're going to go to a new restaurant, you're going to say, oh, let's check out the reviews. Oh my God, they have 500, reviews and they're at 4.8 stars. That looks pretty good. That means an awful lot of people like them. I'll go there too. So that's how people find you digitally. A lot of times you're going to have patients, especially as you guys get more and more into complete care, you're going to have an awful lot of patients, and you're going to love this, and they're going to come to you from two sources, your own patients and other dentists. I will tell you in my practice, we get a lot of patients from Google reviews digitally, they find our website, whatever that is, but we get a ton of patients from our own patients and other dentists in the community. That's everything that John has started to teach you. When you raise your clinical bar, your patients are going to refer you more. So imagine a new patient calls up and they say, hey, and Dave, how'd you get here? Well, David Rice sent me. Now, two things I know. One, remember, birds of a feather flock together. So if David Rice and this patient are really good friends, they probably have a similar style. Number two, we can use that same law of the herd. Hey, you know what, Mr. or Mrs. Smith? So we can make your first appointment here as great as it was for David Rice. Would you have 5 minutes to talk to me today? Now ask yourself this. If Donald Trump's on the other end of the phone, type in, just chime in here in the chat. If Donald Trump's on the other end of the phone and I ask him for 5 minutes on the phone, do you think he's going to want to have a conversation with me? Yes or no? No, absolutely. So now we just have to be careful, right? Because maybe the person on the other end of the phone isn't a high D. Maybe they're just really busy. Maybe they're in the car and they have 3 kids in the back and one or all of them's having a bad day and they're rushing around and it's just not going very well. So Lori on her phone, that's one of her go-tos. So we can give the same great experience we gave Dave. Do you have 5 minutes? No. All right, let me ask you this. Is there a better time where we could touch base later today or tomorrow for that 5 minutes? Now, if it's a task-driven person, you're still going to hear no. If this is the people-driven person who simply is just overwhelmed in the moment, if this is an eyes, what are you going to say? Heck yes, I want to get on the phone, right? Or you're going to say yes immediately. So an I is going to say yes to that question because they're happy to talk to anybody. Awesome. Anyone who answers the phone in your practice is going to realize that the most difficult part of an I on the phone is getting them off the phone. And S is also a people person. So maybe they're not going to be really excited about talking to you because they're a little more shy, but they'll say yes to you because they want to please you. They're people pleasers. That's awesome. But task-driven people, different animals on the phone. So we're always trying to figure out on that very first phone call, do you live on the people side or the task side? We're also trying to figure out if you're a person who believes that you have power over the world or the world has power over you. Those are two very different styles. So both Donald Trump and Lady Gaga believe they have the power to change the world. Nothing's going to get in their way. Let me check. Will an S carry a passive-aggressive tendency? We'll get to that. So picture Donald Trump and Lady Gaga, and they feel like nothing can stop me. And if something gets in my way, and they say, hey, and Dave, how'd you get here? Well, David Rice sent me. Now, two things I know. One, remember, birds of a feather flock together. So if David Rice and this patient are really good friends, they probably have a similar style. Number two, we can use that same law of the herd. Hey, you know what, Mr. or Mrs. Smith? So we can make your first appointment here as great as it was for David Rice. Would you have 5 minutes to talk to me today? Now ask yourself this. If Donald Trump's on the other end of the phone, type in, just chime in here in the chat. If Donald Trump's on the other end of the phone and I ask him for 5 minutes on the phone, do you think he's going to want to have a conversation with me? Yes or no? No, absolutely. So now we just have to be careful, right? Because maybe the person on the other end of the phone isn't a high D. Maybe they're just really busy. Maybe they're in the car and they have 3 kids in the back, and one or all of them's having a bad day and they're rushing around and it's just not going very well. So Lori on her phone, that's one of her go-tos. So we can give the same great experience we gave Dave. Do you have 5 minutes? No. All right, let me ask you this. Is there a better time where we could touch base later today or tomorrow for that 5 minutes? Now, if it's a task-driven person, you're still going to hear no. If this is the people-driven person who simply is just overwhelmed in the moment, if this is an eyes, what are you going to say? Heck yes, I want to get on the phone, right? Or you're going to say yes immediately. So an I is going to say yes to that question because they're happy to talk to anybody. Awesome. Anyone who answers the phone in your practice is going to realize that the most difficult part of an I on the phone is getting them off the phone. An S is also a people person. So maybe they're not going to be really excited about talking to you because they're a little more shy, but they'll say yes to you because they want to please you. They're people pleasers. That's awesome. But task-driven people, different animals on the phone. So we're always trying to figure out on that very first phone call, do you live on the people side or the task side? We're also trying to figure out if you're a person who believes that you have power over the world or the world has power over you. Those are 2 very different styles. So both Donald Trump and Lady Gaga believe they have the power to change the world. Nothing's going to get in their way. Let me check. Will an S carry a passive-aggressive tendency? We'll get to that. So picture Donald Trump and Lady Gaga, and they feel like nothing can stop me. And if something gets in my way, I'm going to figure it out. One of them's going to bulldoze their way through. The other one's going to energy their way through. But look at an S and a C. Those are people who believe the world has power over them. So that's a very different person. So we're trying to learn these styles right away. Let's walk through them. This will be fun. All right. And this is the, we're going to play along here in this chat. So hang in there with me, guys. This is going to be fun. I want you to start thinking about what matters most to a D. And we kind of talked about that. Talked about time. We talked about results being top of mind for that high driver patient. So on the phone, we dealt with how do we treat them on the phone? What should we do on the phone? Do we want to have a really long conversation with them on the phone? Or do we want to get on the phone, get the facts, and get them in? Yes. Awesome, Becky. We want to get the facts. And the more that we just get the facts from Donald Trump's on the phone, the more they sit back and they go, huh, man, this dental practice gets me. This is different. Because the last dental practice or my physician's office or the 50 other places I called today, they wanted to ask me 1,000 questions. I'm not interested in 1,000 questions, but somehow Lori from East Amherst Dental Center, she figured me out. And instead of going through this long diatribe, she got the high points. Donald, do you have a problem I need to get you right in for? No. Awesome. This is what our appointment looks like. Boom, 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 boom. Do you have an urgent need? Yes. When can you get here? When can you get here? So we start seeing all these different ways that we can start learning more about patients. So on the phone's powerful. We start to build rapport immediately, and that's different. That's going to set you apart from every other practice if you guys invest in phone skills with your team to help them identify disc style. How about when we schedule Donald Trump? What time of the day do you think we should schedule him? First thing in the morning, middle of the day, end of the day? When does a high driver, what's our best time to get him? First thing in the morning, absolutely, you guys are awesome. Yes, think about it, it's really simple. Why? Yeah, you guys are awesome, or AM or after work, great answers. If we schedule Donald Trump first thing at 8:30, then we could be out there waiting at 8:15, can't we? And now think about this. Think of why it's so important to know who Donald Trump is before he comes in. Because imagine he's a brand new patient to your practice. You're trying to make a tremendous first impression. And Donald Trump walks in the door, and you or an assistant or someone on your administrative team is ready, waiting. They stand up and they say, "Hey, Donald, it's great to meet you. Welcome to East Amherst Dental Center." And all of a sudden, instead of him looking at his watch and toe tapping, he's looking at his watch going like, "Wow, that's impressive. I'm not due till 8:30. And these people are already ready and waiting for me." He starts to understand that you value what matters to him. And that's when people's shoulders start to relax, breathe a little easier, and all these people you think are really strong drivers, they start to become me outside of work. Because remember, at work, I'm a high D and I'm a high I. And at home, I'm a high I and a high S. So I lose my DI and I dial up my IS, and all of a sudden, like you're a friend because you're treating me like my friends treat me, treating me like my family treats me. It's amazing what happens. Yeah, thanks for chiming in, Vidya. That's awesome. So we talked about scheduling them, walking in the door. Donald Trump's easy, right? We're gonna be early. We're gonna be early, and I'll tell you guys a phrase I learned from an early mentor of mine that was a friend of Jones as well, Walter Haley. And Walter Haley, like, he beat this into me 25 years ago. He's like, "David, early is on time is late, and late is lost." So you especially want to be early for Donald Trump. It really impresses them, and it sets the table, and it frames your whole appointment, because before he ever sits in a consult room or a treatment room, he feels like this is different. And guys, I'm here to tell you, being a great clinician is awesome. Being different and being unique is the strongest marketing principle on the planet. So we've got scheduling, we've got walking in the door. How about educating Donald Trump? And you don't have to chime in on this, feel free if you'd like to, but think about educating Donald Trump. Is Donald Trump my partner Mark, who wants like all this stuff, things to read and research, and maybe you bring out the whiteboard in your treatment room and you draw a picture of the joint, and you explain to him why the disc is where it, no, he doesn't want any of that. Yes, short and sweet. He or she is a bottom line person. Now, that doesn't mean that you shouldn't educate them well. What it does mean is when you want to educate a high driver well, we have to frame it. So we have to share with the Donald Trumps of the world, "Hey, Donald, you know what? Remember on that first appointment about 15 minutes ago, and you came in and I asked permission to share everything that I see?" Stop talking. Yes, because that's going to be him, right? Yes. Okay, well, I'm seeing a lot of things here. I have two choices. I can share them all with you so you have a really deep understanding with it, or I can just tell you what I need to do to get all the records and then talk to you about it. What would you rather I do? Now he has a choice, and you can tell him, "I understand how important your time is to you, Donald, but these are things I need to do to dot our I's and cross our T's, or you're going to get in trouble later on." And what Donald Trump's male or female understand, especially if they're travelers, and that's why time is important, is the last thing they want to do if they trust you as their go-to dentist is wind up on a plane in another city or another country when you're the person they have some faith in. So Dr. Dawson always talked about really sharing risks with people so they understand it. So sharing risks with Donald Trump is really important. It doesn't have to be a long conversation. It's fast. Follow up, super important. I want you to follow up with every patient. And Donald Trump probably doesn't want to talk to you on the telephone. So you're going to follow up with him. First, ask him, "Donald, I want to make sure you're okay. Does it work if I follow up with you after today's appointment?" If he says no, don't do it. If he says yes, say, "Great. Is it better for you if I call you, email you, or text?" Listen. It'll probably be text, so he doesn't need to talk to you. And then just shoot him a little text. "Hey, checking in. If you're okay, don't even answer. If you need me, message back." Piece of cake. Piece of cake. Let's talk about eyes, our influencers, because these are different people. Now remember, D and I, we can both change the world, but we change it for different reasons, because task-driven, people-driven. So no text Twitter. That was well played, Robert. Well played. So let's talk about Lady Gaga, and she comes into your practice. What matters most to her? Somebody chime in as we talk here. What's the most important thing to Lady Gaga as she comes in? She wants to look good. She wants to feel good. Relationships, awesome answers, awesome answers. Talking, yes. Yeah. So how do we need to treat Lady Gaga when she walks in our practice? What do we need to do? We got to have a little party, right? We kind of joked about that earlier on. Yes, great, Kevin. They have to be the center of attention. So in our practice, where Donald Trump walks in and we're serious, but we're early. When Lady Gaga walks in our practice, we're ready right on time. And as many of us as we can get out there to throw that party and roll out the red carpet for him or her, that's what we're going to do, because that makes that patient really good. Yeah, bubbly personality, so important. Having a party, yes, we have literally had parties for some of our patients. All great answers, guys. But again, rewind. We have to figure out who she is on the phone. She's going to be easy, right? She's going to want to talk to Lori and Sarah on the phone. He's going to have a hard time hanging up the phone, right? So Lori's going to be like, oh my God, David, I've been talking to this person for the last 30 minutes. But I want you to think about this, because each one of these you can look at and say, I don't know if I really want Donald Trump's in my practice. But you want somebody who shows up early, wants the best treatment, has the money for the treatment, doesn't really want to ask you a lot of questions, pays you when they leave, and then walks out the door. Because that's a typodont. And if you can find me a typodont, like 3,000 typodonts, I'll take them. And then think about Gaga, because some of you are doing this, right? If you're not a high I style, for all of you C's out there, you're like, I can't stand when Lady Gaga walks in. She won't stop talking. That's my only time I really want to use a rubber dam, because I can finally get him or her to stop talking. But what's the strength of Lady Gaga? What does she have that you want that helps her, but helps you help her? Referrals, yeah, love it. She's a referral machine. She is your patient who's in the chair, who's taking selfies. And I know for you high I's, you think that's the most fun thing in the world. And for you high C's, you literally, like you're having a stroke in the chair. Don't have the stroke. Leverage it. Let Lady Gaga refer you 50, 60, 100 people, because she's got millions of friends. So it's a really good thing. Okay, so when do we schedule her? When do we schedule this person who talks too much? Ooh, send her out business cards. Great point, Emily. We've got to schedule her at a time where we can run late. Awesome, you guys got it, right before lunch or end of day. Because heaven forbid we run 10 minutes over, we've got a buffer at lunchtime, or we've got the end of the day and nobody else coming in after him or her. Awesome, you guys are on it. Perfect. Walk in the door, we're throwing the party. How do we educate Lady Gaga? What do you think for her? Somebody mentioned it, money, appearance, time, trust, comfort, or health. Which one's her? Money, appearance, time, trust, comfort, or health. Appearance, you got it, Emily. Awesome, great job, Ron. So appearance is huge. So Lady Gaga wants pictures, right? So this is the patient we're going to take out our intraoral camera. When you guys, if you don't have one now, you get a DSLR, take some pictures, and here's what I want you to do. Here's your easiest home run first step with this person. Take a picture of them smiling pretty close up, leave it on your monitor, and walk out. And walk out, you don't need to walk out long. Walk out for like 2 minutes. That's going to seem like 75 hours to Lady Gaga. And by the time you come back, she's going to have self-diagnosed all the things she doesn't like. Or take occlusal views. If she has 40-year-old restorations in there that are fractured and breaking down, or broken teeth, he or she's going to be like, oh my God, like, how do you make that go away? So you want to speak to each patient in a manner that they like to be spoken to and they understand. That's why DISC is so valuable. So education. Following up, Gaga's going to want to talk to you guys. So here's how you get off the phone with Gaga. Just like you asked Donald Trump, hey Gaga, listen, I want to make sure you're okay later. Is it okay if I check in? Yes, absolutely check in. Do you want me to call, text, or email? Oh, phone call, please. All right, Gaga, I'm just giving you, FYI, heads up. I'm going to call you at, name a time, 5:15. I'm going to have to like 5:25. because then I'm going to do X, Y, Z, fill in the blank, whatever it is you're going to do, and give her or him a time frame. So when you need to get off the phone, it doesn't feel rude to you anymore. It's the time frame you've already established. All right, let's talk about Garth Brooks. Even keeled. What matters most to Garth Brooks? Chime in if you guys want to. Think about how we treat Garth Brooks. On the phone, comfort and trust. Yep, nailed it. You guys are nailing it. Awesome. So we've got to be different. He or she's a people person, but I got to dial it down. So if I'm Lori in my practice, I need to get more soft-spoken. I need to slow down my pace of speech. And I, most of all, when Garth Brooks walks in my practice, I need to keep an eye out for him, right? So all of you S's know, you've probably all at some point in your life snuck in a room, snuck into a party, snuck out because you were a little bit, I don't know if I really want I'm not Gaga, I don't want that spotlight on me. So we have to treat them differently. Somebody said here, family decision maker. Excellent point. Excellent point with Garth Brooks. We might need somebody there to help them make their choice. Because if they are in a long-term relationship with somebody, they're going to want to make sure their significant other is also okay with this $20,000, $30,000, $40,000 treatment plan. Makes sense? It's your dental assistant. That's awesome. We have really well balanced in our practice. So Garth Brooks, we're going to talk on the phone. We're going to slow our speech down. We're going to slow our pace and our volume down. We're going to really try to build a relationship. We're going to say things. We're going to frame things like, we don't want you to worry about complete dentistry. This is how we treat all our patients. Law of the herd. It's how we treat all of our patients. And it goes well every time. We work really hard at this. These are things you're going to train your team on how to say. So I'll give you some more information before we leave here today, but on how we're going to train our team. When do we schedule Garth Brooks? And this is cool because remember, these S's are 69% of the population. So when you guys learn to speak to each style, you're going to have a healthy grouping of S people. So I'll just let you know, we schedule an S whenever we want. Whenever we want to. Ask what's best for them. That's great. Dana, anytime. Great answer. We try to help that S find a spot on our schedule at our greatest downtimes of every single day because they're going to be happy to help you. This is the only patient who's going to be super happy to help you inherently until they get to know you and you have got great trust built. Then lots of your patients will do that. Educationally, this is really, really important. And this is a tough one. This is a tough one when we start talking about complete care because we have a lot of things to talk about. And a lot of things can be very overwhelming to an S. So what we want to really be cautious of, somebody brought this up in a chat as an excellent point, is if you get the sense that this explanation, this education, the treatment is overwhelming, then try to have a significant other, some loved one, mom, dad, brother, sister, whomever that person has that's closest to them, have them present if you're live. If you're doing in the immediate future, if you're doing this virtual, have them present for that conversation. These patients need a little more hand-holding. So we need some help to get them over. I don't want you to skip the education. It's very, very important, but they need help to say yes, not because they don't trust you, because they're afraid. So they just need a little bit extra. And last but certainly not least, our Cs, right? This is a lot of you, so this is our wheelhouse. These are the people you were taught to educate in dental school. So this is the easiest one of all. How do we treat them on the phone? Task-driven people person, right? These are task-driven people. So a C is probably going to be a person that when they have a conversation with you, because they're nice people, they're going to ask you a lot of questions. My favorite C patient, no kidding, I still remember her to this day. Can't tell you how many years ago it all blends into me, but my favorite C patient was an 87-year-old woman who called in and said, how many crowns has David done? What materials were they made out of? How long did they last? When they failed, why? And Lori walked back with this look on her face and she's like, thank goodness we studied all this stuff because otherwise that's a nightmare phone call. But these are patients who are going to need us to be on point. And John made a really great point. during the Q&A last time. This is why it's so valuable for your team to understand the dentistry as much as it is for them to understand this conversation we're having right now. Because imagine whoever talks on the phone all day had to come back and get you every time. But if they're armed with both sides of this, you have a really powerful team. So we're going to schedule C's. C's are pretty flexible, so that's not a biggie. When they walk in the door, we want to be professional. Remember my C. We want to be professional. We want to be, a little more straight up and down. We don't want to get too excited. Educating them, again, this is what you learned in dental school, so this is kind of a piece of cake. They want all the information. They just might need some time to make their decision. So this is your ideal patient who needs complete care. When you tell them they need to come back for a records appointment, they're excited. This is exactly what they want. And follow up. So I'm going to kind of crank through here to get you to a better spot because we are just about where we are. I promise I'll give you guys all this information. I want you to remember this. Talking dominates a conversation. Everybody in the planet that you meet who has any relationship with you really would rather talk a little bit about himself than hear about your day. So ask great questions. That's what we're going to talk about. When you ask a question, I want you to ask this one as a follow-up. I want you to dig a little deeper so as you get a piece of information and you learn about somebody's behavioral style and they tell you it's money, it's appearance, it's time, it's trust, it's comfort or help. I want you to say, you know what, Mr. and Mrs. Smith? Thank you for that. Can you tell me a little bit more? What does that mean to you? So patients tell you their story. I want you to be radically curious. Let your patient be the fascinating person. You be fascinated with them. Super quick video here. This is life today. This is a reminder of what life is like. This is really, really important for what we're talking about today. Super important what we're talking about today. This is a reality check because this is how a lot of people think. This is 44 seconds from start to cart. It doesn't matter what you're buying, but I know a lot of you are probably Amazon shoppers. Some of you do it once a month. Some of you do it once a week. Some of you, I want to ask you to do it every day. But this is the mindset and a cultural phenomena that's happening today. So patients want what they want, guys. They want what they want it when they want it how they want it. So DISC is very, very important. It's super important. I want to help you guys more. If you drop me your email, just email here to this address, put in the subject line DISC so I know it's in reference to our conversation today. I will get you this presentation and I'll get you more information on some things I know you need to do next. Your first step from here is to sit and digest everything about you. Your next step from here is to do this with your team. But if you email me here, I'll not only share this with you, but John's a buddy of mine. I'll host a free webinar that's all about like next steps with your team and what you actually should do with them to implement them. So thank you so much for your time. I'm hanging out for questions. Let's learn a little together.
That's awesome. And don't forget, you can also catch David on the Go To Dentist podcast with me too. So he's got always has some good things on there too. Good stuff.
Thank you.
What do you got, Joan?
David, some people are asking if there's a book or anything they could read to learn more about DISC.
So yeah, there's always books out there. I'm just going to be honest with you guys. This isn't the kind of thing that a book's going to be your best modality. So like I said, I'm happy to dive deeper with you. We'll make it free. Dawson does an amazing job on the clinical side. I want to help you guys more, so I'll give you more information on it. And then from there, there are other steps you can take. But DISC assessments, taking a DISC assessment is powerful for yourself. If any of you want those, I get them at a discount. I'm not sure, maybe Joan, you guys do too, but we get them at a pretty good break. I don't want to make any money from you guys. So whatever that break is, know what half that was.
it's a very worthwhile thing to do, though, I think. I mean, in
Yeah,
terms of,
it's a super exercise that I would highly recommend to all of you. And then, once you know about yourself, then you want to have a team meeting and do this with your team. That's a great place to go from a second step.
Yeah. I like it, Shelley. You said, what a C move to ask about a book. You are absolutely right. Thank you. And I am a CS, perfectionist pattern. Okay.
That's awesome.
John, what do you think?
I think we can probably, we can, if he follows up and sends the information out, let me maybe do some closing thoughts here. And then, there's still some questions that we can certainly create a documented answer and get to everybody. But I think this was a perfect end to taking what was a very hard, technical, C-oriented lecture and brought a little bit of life into the people business that we're in. So, David, thank you. I'll talk to you a little bit later. You're welcome to hang around and see what I got to say, but we probably got another 15 minutes and then we'll wind up. Okay?
Yeah, thanks for having me, guys.
You're welcome.
Thanks, David. Appreciate it.
You're very welcome.
Okay, John, you're going to share your screen again?
Yeah, I got it coming.
All righty. While John's doing that, I just want to let you know that we put in the chat box a link to register for a webinar Thursday evening with Larry Gazzardo on how to relaunch into your practice after COVID-19. So we'll put that on, I'll put that down in here again while John's finishing up. Oh, there it is. He'll just put it in there for you.
Yeah, no, that's great. He also was on the podcast last week talking about it. If you can catch the webinar, he's great and has some great ideas. I learned a lot doing the podcast with him. But right now there's a lot of things to think about, and we again thinking clinically. But he has a great way of kind of looking at it more from a business perspective and a team perspective. So he's been really helpful for me. So definitely tune into that one, and we'll keep this podcast keep going. Well, let me give you some final thoughts here. And this is a quote that was by Ralph Waldo Emerson. It could have easily been Pete Dawson that wrote this. And Emerson said, "As to methods, there may be a million and then some, but principles are few. The man who grasps principles can successfully select his own methods. The man who tries methods, ignoring principles, is sure to have trouble." I think one of the things that people are so amazed by when they first hear the Dawson Academy, and again, based on some of your comments to me personally on Instagram or email or in the chat box, is it is amazing when you hear these things for the first time. And I'd love to tell you they came out of my head. I've certainly added some things, but so much of this came out of Dr. Dawson's head. And we are a business in a profession that have all these methods of doing things. And I think what's tricky right now is there's so many different ways to fix teeth and place implants. We're starting to ignore some fundamental principles of how the joints, muscles, and teeth are designed to work together in functional harmony. As a profession, we need to ask why more, why things are happening, be curious, and always attach the proper clinical treatment to the actual cause. And I think that's what we do well here at the Academy, and then help you put workflows in place to get that done. But the question that you might be asking is, why the heck do we do all this stuff? And again, it seems like a lot of extra things, but what it leads to is incredibly predictable treatment. These are all faces to you that are popping up, but to me, these are all successful outcomes of people that I got to know and heard their story and connected with on an emotional level, and then worked out a treatment plan that they accepted, that we executed at a high level. And so it's fun to have relationships like this with people. And as a general practitioner, it just doesn't end when you finish with their treatment. They become part of your hygiene, they become part of your family. And so to me, predictable patient outcomes is the juice that makes dentistry rewarding. But it's the predictable patient outcomes that also give you tremendous freedom. And it's the freedom that will allow you to focus on the balance outside of dentistry, outside. Dr. Dawson would utilize this cross of life to make a point that to be really happy, and I talked about it right in the intro, you have to have time for work, you have to have time for play, you have to have time for love and relationships, and you have to have time for some sort of spiritual side. But if we don't have control of our work environment, it is difficult to have these other parts in balance and in harmony with what we're doing. If we care about our patients, if we're not working in a predictive manner, then it becomes all encompassing and we can't get away from it, and we can't sleep, and we can't really be present with our kids and our spouse and the things that are outside of the office that quite frankly matter the most. It was Dr. Dawson who said we need to let a well-run practice be our path to a happy and balanced life. And so Pete had a tremendous impact on my life, but there were two men that impacted me just as much, maybe a little bit more. And the first one was my stepfather, who came into my life when I was about sophomore in high school. And he drilled into my head that I had to learn to live with my life by the 3 Ps. Now, HD was a lieutenant commander in World War II. He was at both Pearl Harbor and D-Day. He had some successful businesses and had some failures along the way. He lost 2 wives from cancer, and then married my mom and stayed married with my mom until he passed when he was 90. But he had just an amazing life. He ran a 411 mile in 1939 at the University of Michigan, so he's a track star. So he's just an amazing person. And yet, despite all this trauma and some tragedy along the way, he just was one of the most positive people I've ever met. He just was always happy. And the 3 Ps were his secret. He said to live life on purpose. He said to align your purpose with passion. And if you have purpose and passion, you'll have the most important P, which was persistence. And that's really going to be my message to you as I talk about my second man in my life that's impacted me tremendously. Is this game of dentistry is not a sprint, it is a marathon. And you have to set vision out there and think about where you want to go. And you can either use trial and error and just try things and fail until you figure out what to do, or you can align yourself with smart people and just copy what they're doing. That's why I hung out with Pete. I mean, I saw what he was doing. I wanted that. So I sucked up everything I possibly could, as young as I possibly could. And it probably took 20 years off my career rather than bumping around and trying to figure it out. So let me tell you about the second man really quick. And this person is the little boy that we adopted all these years ago. You saw the picture of our family. You could see I have one African-American son. He was actually a patient of my wife's. She was an occupational therapist at the Children's Hospital at King's Daughter. And at the time, he was the youngest or the lightest birth weight baby to youngest and lightest. He was a 23-week twin. He weighed 1 pound, 7 ounces. And if you look at that picture of the band around his wrist, that's the doctor's wedding ring. So he was addicted to crack cocaine. He wasn't given much of a chance to live. Spent 6 months in the NICU and then was moved to a vent-dependent unit called the Transitional Care Pavilion, where my wife was working as his occupational therapist. At the time, we were told we couldn't have kids. We were trying real hard, which was fun, but it wasn't happening. And Kim got it in her head that maybe all this was happening because we were supposed to bring him home. And so at about 13 months, against a lot of done some protests of the physicians that didn't think he would ever really amount to anything, we brought him home. And so this is where it sort of starts. So this is in our family known as the Cornell effect. At the time, I was, again, where a lot of you are, just out of dental school, taking some Dawson classes frustrated by my little practice that saving up to buy an autoclave and periodontal probes and all that. And this kid comes in the house that has just so many challenges, and, you know, being told he would never walk or talk, and that he would never really look at us in the eye. And, you know, here we are bringing him home with a trach and a G-tube. And by the time this time he'd weaned off the vent, but he really wasn't doing much of anything. And yet within 2 weeks of being home, I'll never forget driving home with my wife, asking her about what the doctor said about his prognosis. And she just very confidently said, they're wrong. She had a vision for him, and somehow he was communicating with her. And within about 2 weeks, he was starting to come to life and kind of looking at us in the eye, and little smiles here and there. We didn't know it at this particular moment, but Kim was pregnant. We found out a few days later. So Caitlin was born 6 months after we brought him home, and we went from sort of zero to hero. But what I want to share with you is Cornell woke up. All of a sudden he was smiling. He couldn't talk because of the trach, but he started learning sign language. And Caitlin walked at 8 months old, and he was almost 2.5 before he walked. But yeah, when she took her first steps, while as a father I was cheering for him to go first, he was the one that cheered the most and fell over. And so one of the things that Cornell taught me is that comparison is the enemy of contentment. We all are on our own path, and that's what I admire about my son the most, is he's never compared himself to anybody. He's been given a ridiculously hard hand. You don't come into the world at 23 weeks with all the anoxic kits and develop normally. And so you have to be just ridiculously persistent. He just had this passion to sort of find the magic with the moment of the time. So we went through a couple of months or a couple of years with him, and the doctors at the hospital told us it was time to pull the trach out to see if he could talk and breathe. And they found out all the airway above his tracheostomy site, which closed off. So they were going to have to do a procedure where they were going to take cartilage from his ribs, in between his ribs, and graft it into the trach. So cut the trach vertically, graft it in there. But in order to do this, you have to nasally intubate the child and keep him asleep about a week. Now, it was a very, very difficult week, but, you know, we're hoping. So when he woke up, we could tell he was different. A lot of his personality was gone. We didn't know it, but we went through about a 7-week period of time where the grafts were failing, and he would stop breathing, and we'd bag him and get him back to the hospital. And it's just crazy. I was in the hospital a lot of nights and going to work, and I did all this dentistry that I hardly remember. And again, if you've had sick kids, you know what that's like. But my life changed on his second birthday. On his second birthday, my life changed, because it was 7 weeks after they had pulled the trach. He was having all these anoxic hits, and I was in the hospital that night. Kim went home to be with Caitlin. And he got into one of these respiratory depressions where he was pulling so hard I could see every rib in him. And I was looking at his monitors, and his heart rate was over 200 beats a minute. And I knew he wasn't going to make it through the night. His teaching hospital, there were a lot of younger doctors that were around, and they didn't know what to do. And I basically asked them to wake up a real doctor as nicely as I possibly could. And they ran off to get the real doctors, and I was with him, and I was holding his little hand, and I was praying. And if I'm honest with you, what I was praying for was to allow Cornell to go be with God. I thought that he'd been through too much. I thought the road ahead of him was too steep. And he took a big breath, and he let out all the air, and we waited a few seconds. And next thing you know, his eyes are popping open, looking away from me, and breathing harder than ever, fighting for his life. Doctors came in, they took him back to the OR, they retrached him, and there he was just a few days later at home. the full effects of steroids. His personality came immediately back, once again telling us how important oxygen is. If you're wondering about sleep disordered breathing, oxygen is important. And what I can tell you is at that moment, we had not adopted him yet. He was still a foster care baby in our house, and I was all in. I mean, your actions, he could not say a word to me, but this kid was fighting so hard for his life that I made the decision to exhaust all the resources I had to give him a shot. Your team's the same. They watch what you do more than what you say. And so we need to be the one that sets the vision, that walk the talk, that do what we say, and work the hardest and be persistent as hell. And so, you know, what I would say with you is watching him is that's just been the persistence over and over and over. He eventually learned to drive a car, and it took him 7 times to take the written test. At the 4th time, I sent him a text, kind of, he could tell I was worried about him, and he sends a text back to me and says, "Dad, I know you're worried about me, but this is going to make it that much more special when I pass." Failure was not an option. It was just keeping at it until, and not comparing himself to his sisters who sailed through it, which is so hard to do, but it's his own path. It was his own time. He taught me that desire is the prayer of creation. Here we are a year later. Now he's talking and walking and running around and talking back and doing all the things that a 4-year-old should do. So what I want to share with you is this kid changed me. If I'm honest with you, I was a pretty above average student. Things were fairly easy for me, but I really wasn't 100% guy. I was probably applying myself 80%, and I really didn't have the joy in dentistry. And going through this with him, he changed me. He made me go all in. He made me realize that the blessings in my life that have been given, my gift back is by doing the best I possibly can. And so, you know, when you change your sights of where you want to go and you give that little bit more effort, what I promise you is you can't see it in the moment, but over the course of time, it completely changes the trajectory of where you'll go. I would not be sitting here teaching you if I had not had that experience. I don't know if I had it in me. But the combination of being taught the information by Dr. Dawson and the combination of Cornell shaming me into being better is why I'm doing the things I'm doing. And so we all have the capacity to control that. So along the way, he's now about 14 in this picture. We had Caitlin. Kristen came along a few years after that. There's my beautiful wife, who I'll be married to for 30 years in a few weeks. But what I want you to just understand that I love dentistry. I love it. I love everything about dentistry, but it is one part of my life. It's just like Dr. Dawson. That was probably the biggest thing he taught me, is that do the dentistry at the highest level you possibly can do it, but then get outside the walls of your office and be completely present with your family. Have great relationships. Fall in love with something you like to do, like fishing or golf or whatever it is, and have a close relationship with God. Have a spiritual side. The time is going to fly by, right? I mean, these pictures seem like last week to me, and then they go through these awkward stages in their teenage years. But these people that I spend time with are the whole deal for me. And I think we can all say that about our families. My kids are grown now, and so Kim and I are kind of able to do some things together. I want you to think about this, but time and security are the most valuable benefit of being a dentist. You're never going to be like Oprah Winfrey rich, but you will have enough. If we take great care of our patients, if we do the right thing for the right reasons, and we learn to do it predictably and efficiently, you're going to have enough. And by doing so, we will be able to live all aspects of our life with incredible intention. Of the 4 food groups of our life: the work, the love, the spiritual side, and the play. Kristen now is 22. She's graduated from Virginia Tech. She's actually at VCU now in her master's program in special ed, and she has a wonderful photography business. She's a wedding photographer and engagement photographer. You've heard about Caitlin, who's my middle daughter, who also went to Tech. She's just finished up at U of L, actually took her written boards this morning. So all that's left now is the state board exam, and she'll be joining me. Unbelievably, just unbelievable to have a child following you in your footsteps. And then there's Cornell, and what I want you to just kind of appreciate is I took all these pictures, these snapshots frozen in time, and yet I don't ever remember ever really seeing him change in the second. It was just a kid with an insatiable appetite for life that got up every day, put a smile on his face, didn't think about the challenges, and got a little bit better at his own pace. What does Cornell's story have to do with you? It has everything to do with you, because we don't have to have a story in our head. We don't have to think about what the person is driving down the street or where the dentist across town lives. It's your story. You get to write it. You get to choose your vision. You get to choose how you're going to write the story, but you got to write it. You got to get up every day. You got to have a good attitude. You got to lead people. You got to learn to communicate. You have to learn how to deliver the care. But this is a marathon, not a sprint. You can do it over time. But think about hard. When you come off a class like this, think hard about where you want to go. Because if there's a fourth P in all this, there's possibilities. And that's what I want you to leave with. I want you to see the possibilities of where we are in dentistry right now. We are sitting, even with all this COVID-19 stuff, there's certainly uncertainty, but we know more about biologic disease. We know more about functional disease. We have more solutions for patients than ever before. We have a baby boomer population that's aging, that does not expect to lose their teeth, that's spending billions of dollars on appearance and health related issues. This is the time. This is the time to be a dentist. But the one thing that you have to be able to do is be beyond usual and customary. You have to be able to solve problems most people can't. So I'll leave you with this. If you commit to this path and you make a 0.1% change to your practice each and every day, your life, career, income, and practice will be unrecognizable in 5 years. You will be in a completely different place. You will be breathing rarefied air, if you will. It starts with understanding where your patients are, understanding them not only from a biologic and functional standpoint, but as David talked about, even a emotional and behavioral standpoint. We have to do a better job understanding where the patients are and not just treating them in one specific fashion. We have to align what we're going to do for the patient based on their disabilities, whether they're functional, biologic, and then help them understand what we are going to do with good leadership and good communication skills. Our process at the Academy starts with where you are now. We would love to have the opportunity to do more training with you. If the core curriculum is your next step, great. If not, keep abreast of what we're doing on our website or on my Instagram. We'll be announcing our free webinars and our one-day classes. But I just want to say that this has been an unbelievable experience for me. The outpouring of support for the Academy and wanting to do this training, it just means so much to us. And I hope sincerely from my heart that we have exceeded your expectations. So with that, Joan, I just want to say thanks. We got to throw Pete up there, and I think we're right at 5 o'clock. Any final words?
We are. Thank you, John. I have known John since 2003, and knew the first time that I met him and heard him speak that he was the person that we needed to be side by side with Pete, and then to carry on for Pete when Pete was no longer here. John, I don't think there's another person on the planet that could relay these concepts better than you. So thank you. Thank you for maintaining your energy for 2 days in a room by yourself. I felt like I was right here with you, and I hope the rest of you all did too. As John said, we hope that we get to see you in person in one of our hands-on classes. If you didn't catch the email address for Kim, just email info@thedawsonacademy.com, and we'll help you get set up for your next steps. And for those of you that are international, you can email us also, and we'll help figure out where the best place is for you to avail yourself of this training, because we know that it's the best thing for your patients.
Absolutely.
I'm a unstable person. My joints are unstable, have been, and so this is very meaningful for me personally. I also want to thank Dr. Raj Apadia, Dr. Steve Ford, Dr. Lenny Hess for behind the scenes typing furiously
Crazy.
to all these questions today. We actually answered 648. I know there's a few more. We'll try to get some answers together for you on those and send them out.
And
Watch
also,
your email. Go ahead.
And also Greg and Phil behind the scenes too. And
Yes,
you, Joan.
Greg
It was the Dawson team.
That's right.
Yeah, man.
And,
John, I just wanted to mention that a lot of the links and everything will be gathering tomorrow. So when we send out the addendum with the link for the recording, we're going to try and encapsulate as much stuff so that we're not like throwing a million emails out there. So just keep your eyes.
Great. That's what I was just going to say, Greg. Thank you. See, that's why we have Greg. Terrific. And thank you all. Just know that we're here for you, and we hope that the Dawson Academy becomes as special to you as it is to all of us.
Yeah, thanks again, everybody. God bless. We'll see you soon, we hope. Take care. Bye-bye.
Bye-bye.